morning and welcome back. And welcome to those who weren't here with us yesterday. I want to ask all of us to please turn your mobile devices to silent. You may notice board members accessing their laptops, phones, or other devices during the meeting. They are using the devices to access board meeting material that are in electronic format. If you're a member of the media and require assistance or information, please see Aaron Bone. Aaron, please identify yourself. This is an official business meeting of the Medical Board of California, and disruptions of the board's business will not be tolerated. Government Code number 11126.5 allows a board to remove people who willfully interrupt a meeting and to clear the room if order cannot be restored by removing or muting the disruptive people. The board welcomes public comment on any item on the agenda, and it's the board's intent to ask for public comment prior to the board taking action on any agenda item. If for some reason I forget to ask for public comment on an agenda item and you wish to speak on that item, please raise your hand and come forward and you will be recognized. This meeting is again being streamed via WebEx. Individuals attending the meeting remotely via WebEx will have an opportunity to provide public comment and will be assisted by the host who will be facilitating the WebEx meeting. During each agenda item, the host monitoring the WebEx event will activate the hand raising and Q&A features of WebEx and will ask anyone wishing to make a public comment to indicate so by raising their hands or entering yes in the Q&A window. The host will then call on individuals who indicate they wish to make public comment by name provided by the individual, which may be a pseudonym. When called upon, the host will unmute the microphone of the individual and they will have 3 minutes to make their public comment, but this time period may be reduced depending on the number of people who wish to speak, so that more people may be heard. The host will audibly announce when 30 seconds remain to conclude the public comment. After the individual's time for public comment has lapsed, the individual will be placed back on mute. Only one public comment per agenda item is allowed per attendee. I want to remind all speakers to please stay on task. Keep your comments to the allotted time or less. Today's meeting will be run according to the Open Meeting Act as required by law. We plan to end the meeting by 3 p.m. There may be a lunch break. I'd like to call the meeting to order. Ms. Stroller, please call the roll.
Dr. Bolat.
Present.
Dr. Deengra. Dr. Helzer.
Here.
Ms. Jong. Ms. Lawson.
Here.
Ms. Lubiano.
Yes.
Dr. Mahmood.
Yes.
Dr. Thorpe. Dr. Sai.
Here.
Mr. Watkins. Dr. Yip. Dr. Hawkins.
Here. Moving on to agenda item 10, a presentation on rethinking autism, identity, not disease. I'm pleased to introduce our presenter, Dr. Alice Kuo. Welcome, Dr. Kuo. Dr. Kuo is Professor in Chief of Medicine and Pediatrics and Preventive Medicine at the David Geffen School of Medicine at UCLA and Health Policy and Management at the UCLA Fielding School of Public Health. Her research interests include access to and delivery of developmental services, health disparities in marginalized communities, transitions to adulthood for children with special health care needs, and services for children and adults with autism and other neurodevelopmental disabilities. Dr. Kuo is the principal investigator of the Autism Intervention Research Network on Physical Health and director of the University of California Leadership Education and Neurodevelopmental Disability Program. She is the medical director of the UCLEND Clinic and has a primary care practice for neurodevelopmental patients of all ages in Santa Monica and Redondo Beach. Dr. Kuo, welcome, and you may begin.
Thank you very much. Is this working? Okay. Thank you so much for having me. Over the next, I think, 40 or so minutes, I wanted to share a little bit about what we've learned and how we're thinking about autism in our programs. Next slide, please. So I wanted to start with well, there's a disclaimer, yes. We are funded by HRSA, which is a federal agency. Next slide, please. Yes, so I wanted to start with some terminology. In this space of neurodiversity, I think it's important to understand that as providers, as physicians, we can alienate our patients if we are not aware of certain terminology that has evolved in the field. So there has been a long-standing debate about how to refer to autistic people. So identity first versus person first means that we say autistic people instead of people with autism. And the reason for that is because the people with lived experience have come forward to say, I don't see my autism as a disease. I don't see it as something separate from me. You don't say a person with athleticism or musicality. You know, I am an athletic person. I am an autistic person. And so this is the trend, although sometimes if you're unsure or if a person refers to themselves as a person with autism, then you check, right? You check with them and say, how would you like to be referred? On the spectrum, if it's sort of unclear, is acceptable. But this is evolving, and I think just being even aware that there's this issue can help a provider be more perceived as accepting or, a friend, like friendly. So autism as an identity as opposed to a disease or disorder is an emerging area because, and the next bullet point, high functioning, usually implies an autistic person without an intellectual disability. And so the term high functioning is a lay term to say, okay, I know somebody who is high functioning autistic, implying that they can pass for normal, which is not exactly what autistic people would like to be perceived as. But I think that high functioning is a misnomer because there are autistic individuals without intellectual disability who still have high needs, whether it's on a social structure or, from that perspective or mental health issues. So functioning is actually not quite appropriate. And Asperger's syndrome is an old DSM-4 and prior diagnosis that no longer exists. But you have older people who may consider themselves Asperger or ASPI, and that is not in the DSM-5 anymore. That has been folded into the umbrella of autism. And so then another term is neurodivergent or neurodiverse. Neurodivergent is probably a term most physicians have not heard, but in the field, neurodivergent explains the phenomenon of individuals with different brains who sort of tend towards autistic, whether they're quote unquote formally diagnosed or not. Here, when I talk to graduate students and medical students who have heard this term, I say that the distinction here is neurodivergent is a person and neurodiverse is a group. So you don't say that a person is diverse, so you don't say that a person is neurodiverse, you say a person is neurodivergent. And so then it comes to the last bullet point, which is, not to think of autism as abnormal, because it is very grating to autistic people to say, I'm not autistic, I'm normal, as if you're implying that being autistic is not normal. And that is still, that is changing in society faster than it's changing in medical language. So I think that, being sensitive to talking to an autistic person or in front of an autistic child or person in front of their family and using terms like normal as if implying autism is not normal can be very offensive. Some people think that neurotypical is a way to distinguish between autistic and non-autistic. So if you're not autistic, you're neurotypical, but then typical also implies that being autistic is atypical. So it's just being aware that there are these language things that from the beginning of a medical visit, you could be inadvertently offending the person in the room if you're not aware of some of these. And so we did publish an article in the journal Pediatrics in April, which is April is Autism Acceptance Month. I think we are moving past awareness, so people who still refer it to Autism Awareness Month, is the autistic population don't just want to raise awareness, they want to be accepted in society. So Autism is April is Autism Acceptance Month, and the April issues of Pediatrics and other child-oriented journals often will have a special issue on autism. So in 2022, our group put out a supplement, and one of the articles is written by autistic researchers about terminology, and I'm happy to provide that reference if you guys want it. Next, oh, perfect. I started in this area maybe 12 years ago now. This was the first study that I did. I had done health services research and developmental services prior to this in public health, child health policy. And I conducted this autism case confirmation study for NIH back in 2012, and I added this qualitative component, which allowed me to interview about 25 parents of young autistic children, 3 plus or minus, 10, 12 months, about their identification / diagnostic process. So they had just received this, news that their young child was autistic, and I had the opportunity to ask them about that process. So what I wanted to share were just, a few quotes that have really been foundational to my thinking about delivering autism care in a way that is much more responsive to the needs of patients. So one, this was from a mom. Our son was always so sweet and calm and didn't require much. It seemed like he was content that way. He never really fussed. He liked going down to bed. Up until my son was 14 months old, I thought everything was fine. And so this kind of speaks to, how different it can be for families to get that diagnosis or that identification, and how it can really change their view of their child. This was from a very frustrated dad, I'll never forget. First, you need to go to your pediatrician, and the pediatrician has to make the referral to a specialist, and after you see the specialist, that's when you get the diagnosis added, but that takes a while. The only thing I get very, very mad about is the process to get everything done takes so long. Like for my son, I had to wait months to get just a hearing evaluation, and I think it's just wasting time. And you can't get the services during that time because you don't even have the evaluations yet. And if you're in the field, you know that now to see a developmental specialist takes anywhere from 12 to 24 months in Los Angeles County. So that's a very long time to wait. This was from another parent. When you feel like a child has their own personality, you don't really want to change it. Every child has their own personality, and I thought my son's autism was his personality. So me trying to break into that world was something I was apprehensive to do. And I think that really, again, speaks to the fact that you can't distinguish autism from the person, the child, and it's not a disease that needs to be treated. And then this is, I think, really, this is the one I tell all the pediatric residents. It was intimidating to have someone tell you how to parent. It was a challenge. It is the biggest blessing and the scariest thing at the same time. It is really exposing, how vulnerable and blessed we can feel at the same time. So I teach the residents, you have to acknowledge that parents are the experts in their children. Right? Because if you come in trying to tell them how to parent, what to do, how to manage certain things, kind of in a, I don't want to say paternalistic way, it will not land right. And the other thing too is we're not spending 24/7 with that child. We're spending 15 minutes maybe, 30 if you're lucky. And so partnering with parents, I think, is really the most important thing. So the lessons learned from this initial study was that gaining an autism identity is a process for everyone in the family. Many parents commented on the feeling of a ticking time bomb or being behind from the moment they get that diagnosis, and that adds a level of stress on the family that just is not really helpful, to be honest. Family support has been woefully neglected in this process by service providers, and families need to create communities of support around them to help each member of the family, each parent, each sibling. And PCPs are really uniquely positioned to support and guide families through this process and be there for the long haul, because the way the specialists work, and we've gotten these reports from families, is you go to see the specialist, they give you all this news, and then they're like, okay, on to the next patient, and they're not staying with the family. And on the PCP side, I get very frustrated with our pediatricians who, find out that a new patient to their practice just moved into the area, the kid has autism or is autistic, trying to navigate the IEP process in the schools, and I'll see on the well child visit follow up in 1 year. The parent just gave you all this information, and you wouldn't think to maybe check in 2 months to see how things are going, knowing that something like IEP services or learning issues or behavioral issues would be involved, and that you as a pediatrician could at least lend support and make sure things are getting connected. So I really saw that the PCP was being kind of let off the hook for these autistic children. So family support is key. And again, guidelines or advice I give to the residents: listen, don't make blanket recommendations, gauge what families can handle. Parents need time to grieve the loss of the ideal child. This is not unique to autism. This is, similar to any child with any chronic condition, any child that gets a congenital heart or a cancer diagnosis. Parents never think that they're going to have that happen to them. So understandable that they need a process. They need time to adjust. A longitudinal continuous relationship is important. And so every family that we meet, I say, we're here, you know how to find us. We're here, when you need us. Don't worry, you're not having to do this by yourself. And that alone is huge advice for families. Normalize the process for them and normalize their child. They're still a regular boy or girl under that autism. I'll never forget, I had an autistic boy come to me, 4 or 5 years old, still not potty trained, and had been diagnosed with autism maybe 2 years prior, and the mom was like, the ABA therapist can't figure out how to toilet train. Like, nothing is working. And I said, have you just tried having him run around in the background with backyard with no diaper on? Like, that's an old thing that we say, try that. And she came back the next minute and she said, oh, that totally worked. And I'm like, pediatricians know this, right? Just because the kid is autistic doesn't mean that regular strategies won't work. But I think, again, for providers, and so much has been made around this myth of autism that pediatricians aren't giving that advice, and quite frankly, the psychiatrists and the developmental pediatricians aren't also giving that advice. So then the parents are kind of in this situation where they're not getting the help that they need. And then understand the ambivalence. There can be caregiver fatigue. We had a situation where we were evaluating a young boy, and the whole family was it was very crowded in the exam room. It was like 2 grandmas and the parents and the child and a sibling, so it was very crowded. But after that initial evaluation where we were like, yeah, we probably need to work this up a little further, the dad called me and said, I just want to let you know, I know you told us to do all this stuff, but I just had to put my wife into rehab for substance use, and I don't think I can handle this right now. And I said, it's okay. Take care of your wife, take care of your family, we'll be here to pick up, And so I think a lot of times, because there's this feeling that autism is this horrible thing and you've got to drop everything and take care of it right now, families are given that perception when they get this 40-page report that has 25 recommendations on it, and it's very overwhelming. And, I've tried to work with our psychiatry colleagues to say, I get it that you think that the autism is the most important thing, but we in pediatrics have a much more kind of family holistic view and say there are other siblings in the family, there's other needs in the family, if there's a parent, struggling with substance use disorder. So we have to help families gauge what they can handle. And so my position has always been, if families felt more supported, fewer of them would turn to kind of desperate and questionable alternative practices where they're going, searching for chelation or checking heavy metals and things like that. In my practice alone, I've never had families go turn to that when they're getting this kind of support that they need. I just wanted to point out that our current research investments in the U.S. are, significant, almost $400 million going towards autism research. 85% of it is going towards preventing it. Screening and diagnosis, genetic and environmental risk factors, underlying biology. So this is also a sticking point for autistic people because so little of this money is actually going towards helping them lead successful and healthy lives. And if you look, it's only 3% going to lifespan issues, 6% going to services. That's 9% going towards helping a person who is already autistic. Treatments and interventions, this 14% is really focused on early intervention, 0 to 3, which does work. The research is good on that. But autism is not fatal, and 3-year-olds grow into older kids and adults, and very little research is done in that age group. This is what summing up what I had said. So the research network that we have is really focused on trying to reframe the way that autism research is done, and recognizing that the goal is to optimize the physical health and well-being of autistic individuals. And so I'm just wanting to say that we could reimagine these investments and look at funding studies that address things like what it means to be autistic, the whole identification process, the transition to adulthood process, and then lifespan intervention and supports. I just wanted to highlight that this is a health disparity. There are research studies coming out of Europe and other places where autistic individuals, even without an intellectual disability, on average experience 16-year lower life expectancy relative to non-autistic people. And this is due to untreated cardiovascular disease, unidentified or late identified cancers, and mental health issues. And so because autistic people have such poor experience with health systems, they don't come. They don't come for their checkups. They don't come to get their blood drawn for, cholesterol or diabetes. They just don't want to interact with the health system. And so, the statement in red, I think, is the most important. Autism doesn't shorten life expectancy. There's nothing about having a different brain type. In most cases, if you're not associated with like a genetic syndrome, just being autistic is what is shortening life expectancy because of negative interactions with the health system. So this puts autism in the same category as minoritized populations because of race and ethnicity, or LGBTQ populations. Any group that doesn't have a great experience with healthcare is just not going to come. Next slide, please. Oh, the video. Right, so we have training videos for our medical students, so I wanted to show a couple of them. This is the first one. If you can show this video.
Sorry. And for the public attendees, if you have a problem viewing the video through the stream, this
Their sound. You might have to share the sound too.
just a second here.
So about these videos, while he's pulling them up, we made a set of videos to introduce to medical students how to care for patients with disabilities, because that had never been in the curriculum before. So at Geffen, every medical student has seen these training videos for the past 3 years, and we've also given them to all the pediatric residents and internal medicine primary care residents as well. Maybe you could just show it from the browser.
Yeah. I'm just going to play the local file here. Just give me 1 more second. Apologize for the delay.
Uh-oh. If you have the links, you can go.
Sorry, it's trying to play through the progression.
He loves to look at his YouTube videos of different types of.
Sorry about that.
This handsome guy is my firstborn son, Zach. He's 20 years old. Zach is a young adult now, it's hard to believe. He has things he enjoys doing, like right now, he wants to get up and walk. He loves to look at his YouTube videos of different types of songs and books being read. He's a real lover. I'd say that's his greatest strength is how much he loves being with people. I mean, he really brings me true joy. I mean, he really, really does. And I'm thankful every day for him, right? We're so lucky to have you. So lucky. I think his impact in this world is much greater than, right, Zach, than we could imagine. Can I imagine? Another hug? Okay, hug. Hug. This day starts at 6:30 in the morning with medications, toileting. He gets a special high-fat ketogenic diet tube feed for his medications that runs through a pump over an hour. And then that occurs every 4 hours. And then in between times, he'll go on car rides or go for a walk. Let's go for a walk. He basically has needs every 2 to 4 hours the entire time he's awake till he goes to bed at 9:30 at night. Oh, those are days he doesn't have a seizure. I think there's so much I've learned that it's hard to encapsulate into a few sentences, but if I could try, I would say, even though I may have an idea of how I think, and this goes for my life, how my life was going to go, or how my schedule will look for a day, all bets are off when you have a child with special needs, because anything can happen, and his seizures are probably the physical embodiment of how unpredictable life is, right? Because they hit him anytime. If I could emphasize something to future physicians, it would be that take a step back for a moment, even if your day is going badly, meaning, and I've been in this situation, you're running an hour behind, you're backlogged on all your reports and lab testing, but just take a single second to think about what it took for that either child with autism, with epilepsy syndrome, who's disabled physically, to get to your appointment that day. Because, and this is going to bring tears to my eyes a little bit, you don't know the journeys that some of these families have traveled just to be in your exam chair. Because sometimes it means entirely disrupting the family schedule and their medication schedule or their toileting schedule. Some families travel from a really far place just to come to UCLA to be seen. One experience I had, which was one that still stands out in my mind, was the dentist's office. When we finally got into the chair after a long wait, Zach, of course, as is typical for Zach, doesn't understand instructions and wouldn't sit easily for a long period of time. So on this appointment, the dentist had no patience for Zach. He said, this must be a bad day for Zach, so come back another day. And what I wanted to tell him, I was like, this is not a bad day for Zach. This is Zach. We're not going to come back on another day where he's going to magically be able to sit still, listen to instructions. I cannot emphasize enough how important it is for a physician to ask about the well-being of the family member or caregiver for the patient with a disability. It can take a large emotional and physical toll on the family and the caregiver, and to check in with them and to express that empathy can be just the support that person needs that day to get through another day. So it's priceless. I would say we were blessed to be at UCLA, but if I could speak more broadly, I would say that there's a shortage of physicians who have an interest in seeing patients with special needs, doctors in our healthcare system who would rather turn away from seeing and evaluating a patient with disability than taking care of their needs, because it takes more time and energy. That's not acceptable. I think it's really important for young physicians to know that they're choosing a really, really special profession. They have this incredible privilege of being able to see people from all walks of life, and that it's really important when you take that Hippocratic oath that applies to every individual you see, no matter who they are, where they're from, what disability they have. If that's not something that you feel like as a young profession that you can do, then I think it is time to really think hard about why you chose medicine.
Great, thank you. Could you go back to the slides? I think we have to. Great. Oops. Perfect. So as you can see on this slide, this sort of encapsulates the way where I feel like the mechanism of action needs to be for this population, which is, as I mentioned, early intervention does work. So obviously making sure that kids get connected to services as early as possible is important. But then at some point along the green path, the brain plasticity kind of becomes set, right? And maybe around 9, 10, 11 years of age, what you see is what you get. We know that the brain continues to develop until age 25, but what we know is that it is much more difficult, and any of you who are parents know that at some point when you tell your kids to eat the vegetables, they're not going to eat them. So there's only so much that you can do, and obviously in capturing that early time where you can be more impressionable on children is great. But then, honestly, the reason that the stick figure is so much smaller in adulthood is because what needs to happen is more inclusion, right? We need to find roles for these members to have in society, meaningful ways for them to spend their time and be included and participatory, because so many of these individuals, when they grow up, their parents have no place to send them. They're out of the school system. They're having to create programs for themselves. And if there are stressors in the family that prevent them from having to do that, so many of these individuals just sit at home, watching TV, having someone make sure that they don't leave the house. And that's not really a meaningful way of life. Next slide, please. Okay, so this is a life course health development model that was developed at UCLA, and it really talks about going through the health trajectory. And what you can see here is that any individual, this goes for everybody, your path in life is the sum total of your protective and your risk factors, right? So if you are born to a family with a good zip code and good schools, and you have health insurance, you have enough to eat on the food on the table, then your trajectories are going to be more optimized. And then if you don't, and you have social economic risk and other social vulnerability factors, you have risk factors that push your trajectory down. So when I use this graph, I'm trying to tell pediatricians and other physicians that our goal in primary care is to optimize everyone's trajectory to the most that we can. And so pediatricians can't take credit for the fact that kids aren't sick, because kids generally are healthy when they're young. But are you looking for risk factors for mental health issues, substance use disorders, things that can affect their health down the line? Next slide, please. So we don't have great measures of adult healthy outcomes as far as like what matters in life. There are groups in the country looking at what are appropriate transition to adulthood outcomes. But so I say in the absence of that at this time, I go back to Psych 101 and Freud. He said there were two things that mattered to most people: work and love. So are autistic individuals in adulthood able to have some way to participate in society, whether it's paid employment, whether it's supported employment, whether it's a program that they can go to and be with other people? And then are they able to have relationships outside of their family? And the reality is many autistic adults don't. They have relationships within their family, and then up to 90% in some studies have not had any significant friendship within the last 12 months in their adult life, which is, not a great statistic. Next slide, please. So this is a slide that I use to policymakers to say that if you look at autism on two axes, with social ability on the x-axis and cognitive ability on the y-axis, then those with intellectual disability will end up in the red box, meaning that they qualify for services under intellectual disability. So we have regional center, we have developmental disability services in the state of California. That's not an easy path, but it's a clear path. We know exactly what they're qualified for, SSI, IHSS, things like that. So if you don't have a cognitive, impairment or intellectual disability, then the outcomes are more dependent on that individual's ability to socialize, right? And what we would like is for as many people to be in the green box as possible, but what we end up with is kids and young adults in the orange, shape, which, for example, I have a patient who's in his 40s who has 2 master's degrees but has not been able to keep a job because he is a policeman, which is a type of behavior that we see in autism, which is that they're very adherent to rules, and they are, to a fault sometimes. And anytime he gets employed, he reads the employee manual, he memorizes it, he knows exactly what's supposed to be in it, and then when he sees an infraction, he reports it, and it says, please report. He reports it to the CEO, and so it's just like we've told him multiple times, like, there are different chains, but he doesn't get it. He's like, it says to report, so he goes up to the top. So then, of course, then he kind of gets let go after that, and it's happened a couple times. So, those types of behaviors, again, we can support and give feedback. And so I finally told the parent, I don't think he can be employed. We got to think of like some self-employment for him. He's really good at other jobs. Like, let's find something different. Next slide, please. So neurodiversity is this idea that there are brain differences like autism, ADHD that are the result of normal natural variation in the human genome. So this has a strong disability rights focus and sort of nothing about us without us. That's a mantra in this field. It's not a belief system. It's not an opinion. It's not a political position. It's just a neutral fact of human life, like biodiversity. And so it's interesting in autism research, this movement is sort of threatening traditional autism research that has been funded that is looking at like ways to prevent autism. And so some researchers are very threatened by this perspective. Next slide, please. So this is like one of the slides I show my students, which is what Alice thinks slides. So basically what the old model has been like, if your investment in a patient's life over time, it's the blue line. And so then you have more investment in early education, which is, you give them a boost and they get a little higher in the early stages. What we see with early intervention research, though, is that it kind of regresses to the mean. It kind of regresses back to baseline if you don't sustain those investments. And so all this money has gone into 0 to 3 or 0 to 5, and then nothing past that. And so we are not getting great adult outcomes for this population, despite the thousands and thousands, sometimes millions of dollars invested in that early period. So what I think should be happening is this investment sort of throughout time. And I think that primary care is a great investment in that, because there are multiple touch points through the life course that primary care can have, and then also thinking ahead to adulthood. Next slide, please. So how does this look? We have a LEND clinic at UCLA. LEND is a federally funded program that is in 43 states, I think, and some states, the smaller states, kind of partner up. But we have 4 now in the state of California. We have 2 in Los Angeles, 1 in Davis, and 1 at UC San Diego. Next slide, please. So the importance of primary care that I've talked about, this LEND program is embedded in MedPeace primary care because as a MedPeace physician, we can see all ages, so that's nice. At UCLA, even though MedPeace physicians only make up 1.3% of all PCPs, we see up to 18% of all neurodevelopmental patients at UCLA. And we did a data pull from our EPIC EMR, and we in our system, out of 800,000 patients that we have responsibility for, 58,784 have some neurodevelopmental condition, which is 7.3% of the patient population. 24% are pediatrics. And I highlight this because everyone thinks of autism as a pediatric condition, but you live with it. So 72% of patients with neurodevelopmental conditions at UCLA are actually adults. Adults between the ages of 18 and 64, and only 4% are seniors, which speaks to that early death. Next slide, please. So in our LEND clinic, we do not replicate what child psychiatry and DBP do with diagnostics, because that's why they have such a long waiting list. They have come up with, a diagnostic process that is both very expensive and very tedious, and so everybody gets funneled through this bottleneck. As you heard from the quotes, we were trying to come up with a model that is like guaranteed to see everyone within 2 months if a concern. And so these concerns can come to us as like diagnostic clarity. If they do want a diagnosis, the DSM-5 does not say that you need 2 days of testing. The DSM-5 says it's a clinical diagnosis that any physician can make. I think there has just been a culture built and businesses built around capitalizing on the diagnostic process, but it is actually not necessary. And we've also found that during the pandemic, when nobody was doing testing, people still took our clinical diagnoses. And so we've really kept that. Service coordination, mental health, transition planning, a lot of parent support, a lot of behavioral management, and then our most requested service is IEP advocacy. So I have a social work team who helps prepare parents for the IEP process, goes with parents to IEP meetings. I've attended IEP meetings, and honestly, school districts really appreciate the presence of a health provider there to say that this is the UCLA health team, these are our recommendations, and they also recognize that we're different from lawyers, no offense to the lawyers, but we're not being paid. Like, we don't charge for that. So, you know, we're there neutrally to support the child, and the schools will also see that sometimes we will side with the school if the parent is asking for something that is unreasonable. So we're there really to support what's best for the child to help that child thrive in the school setting. Next slide, please. This is where our locations are. Next slide, please. And so what we're trying to do is launch Len Champion in every primary care office at UCLA so that there's someone in that office that can support the other providers in the care of these patients. And so we have trainings that are available to help these providers gain better skills. But honestly, a lot of it is just understanding more about autism, and there are no specialized skills. It's, you know, being a little more patient, being a little more understanding, being a little mindful of your language, and you too can care for this patient population. And the overall goal of this initiative is to decrease the health inequity leading to poorer health outcomes, poorer quality of life, and shorter life expectancy for autistic patients. Next slide, please. This is our training that we provide, and we have trainees from around the country because it's all online since the pandemic. So we have a whole video library. We can make this available to as many physicians as would like to take it. Also, we are partnering with different entities around our ECHO model. So, like Homeboy Industries, for example, sees obviously a lot of neurodivergent patients in the juvenile system and the gang associated system. And so they've asked us to come in and do a training for them, and we can do, you know, weekly trainings for 3 months, we can do monthly trainings for 12 months, however we need to do it. We've been asked by Homeboy, LA County Department of Public Health with their public health nurses, and also recently heard of a request from the state. The correctional system is interested in having us come and do an ECHO model for them. And so I think the goal is to democratize this knowledge so that patients have more access to people who understand this approach. Next slide, please. And so I think this is like towards the end of my presentation. Our practice of caring for thousands of these patients has informed our research and vice versa. And I think we at UCLA Health has been a learning lab to improving care for autistic patients, and we're ready to like disseminate this and let people know that you too can do this in your own health systems. Next slide, please. I think you can skip this. This is the different areas, you know. And what I will say is all of our work is informed with, you could go to the next slide. And the one after this. Answer. So we're working with an entity called Autistic and Neurodivergent Scholars Working for Equity in Research. So this is a group of autistic researchers that we help to organize, and it's run by Drs. Heather Brown and Zach Williams, who both identify as autistic, and Dr. Hotez from our group, who supports them. And they are informing the way that we think about research and setting a research agenda, and it's really working in meaningful and authentic collaboration with them to understand the right priorities. Next slide, please. So this is the final video, and I love this video. He's one of my patients, and I think he is an example of what can happen when a primary care provider is in there over time. He is actually now 18 years old, but I think I've been caring for him for 10 years, and he's doing great. So just wanted to share, you know, a good, happy story.
So I'm going to get shared to the audience. And To the public attendees, the link to this video is in the chat. I know there's some bandwidth limitations in our VPN configurations, creating a little jaggedy action, so you can watch it if you like as well.
My name's Grayson, and I also go by Gray. I am 16 years old. I have a permit, but not doing great on the actually driving. It's a little bit scary. I go to Orange County School of the Arts, and I am in the Popular Music Conservatory where I play electric bass, and I love music. I play a lot of music and listen to a lot of music in my free time, like Nirvana, Green Day, Fall Out Boy, My Chemical Romance.
Gray is a great kid. I am very proud of him. We've worked really hard to get to this place.
Yeah, I have faced a lot of issues.
No parent likes to see their child feeling isolated or feeling socially disconnected from their peers.
Because I was a girl at the time, they didn't look into autism until a lot later, because a lot of the research on autism was only studies of boys. The autism diagnosis I did not get until I think the end of 6th grade, but it was really helpful. Suddenly I was like, this is why I'm like this, and this is why I can't focus, and why it's so hard for me to communicate with people. And I finally understood so much about myself and how my brain works, and it was very freeing for me.
Getting the help that we needed for Gray was critical because I was beginning to myself feel overwhelmed. Dr. Quo and at UCLA, getting us on the right path made all of the difference. And that has been true in every step of our healthcare struggles. When we went to Dr. Quo, it really was because of the neurological issues, the migraines. But we knew, and I said at the time, there are these additional issues that I will want to come back and address with you because we think that Gray, needs some more support and isn't getting all the support that he needs. And that's when we had the discussion more about ADHD and then ultimately autism. By the time Dr. Quo mentioned autism, she had seen Gray several times. So I think it was something that was on her radar that maybe this is a dual diagnosis or overlapping diagnoses.
For parents and maybe kids who have just received this diagnosis, first of all, there's ABA therapy and things where you're trying to train your child not to be autistic. Don't do that to your kid. They're still going to be autistic. They're just going to suffer a lot, and it's just going to set them back a lot. You shouldn't punish them for being different than society. You should teach them how to be a good friend and how to deal with this diagnosis, and just parents, educate yourself and try to educate your kids, especially if they're young or they're not sure what's going on, and just be there for them and be supportive, because it kind of is a lot to be thrown on you at once, but it will help your kid in the long run, and don't hide it for them.
I think there's still a lot of stigma about autism. This is not something I knew a lot about, so this is something I've had to educate myself about as well. I think there's a natural tendency in humanity to be leery of differences and have a hard time overcoming differences or really seeing the things that we all have in common. So autistic kids can feel isolated.
There are definitely times I feel different than my peers, and also at school I know that I learn different, and sometimes when I take tests I have extended times, and for example in my math class we all put our homework into a folder at our table, and since I have extended time sometimes I do it a day late, and I feel weird my peers are collecting homework and I'm oh, I haven't done it yet, and they might think that I'm not smart or I'm not participating, but really it's just because I'm different and I have different expectations in that class. So it can kind of make me feel out of place or I'm doing something wrong, but I have to remind myself that it's okay and that's who I am, and that I need that time to do my best on my work and stuff. Autism is a large spectrum and every person is different, and there are people who can communicate great, but maybe they like really can't handle like sensory issues or textures, or they don't understand sarcasm. There's just so many different parts of the spectrum, and every person on the spectrum is different. I already knew that I was like queer, I was bisexual, I liked men and women. Over COVID, you know, you have a lot of free time, a lot of like time to yourself to think and to ponder. And I was like, well, do I like this guy or do I want to be him? And that's when I sort of started questioning gender identity. Getting like healthcare, especially trans healthcare, wasn't really a problem with me. Like my doctor, my primary physician, was super supportive. When I told her, she was like, okay, what pronouns do you go by? And what's your name? And she put it into my chart. So now when I get like notifications about appointments and stuff, it says Grayson and not my old name. She immediately, like, during that appointment, recommended us to like their gender health clinic and gave us like resources, and my mom some resources since it was pretty new, and just gave us information to where can we start and like what does this mean for you. And I think that helped my mom a lot because I feel like she was pretty lost.
You know, to find the people who embrace his uniqueness, his difference, to succeed in school and to be independent. I mean, I think as parents, you worry when your children are neurodiverse. Is this a kid that's going to be able to succeed out in the real world? And I think a lot of neurodiverse kids do succeed, but it really does take a village to help them succeed.
I am proud of myself. I'm like so much better in social situations, and I know how to make friends and be nice to people and how to be nice to myself. And like when I perform on stage now and see like new pictures of myself, I'm this completely different person than I was a long time ago. I like carry my shoulders higher when I go places, and I'm like excited to introduce myself to people, and it just everything about like myself I'm so much happier with than I was like in middle school and elementary school. I attribute that to like understanding that I was trans and having like my ADHD and autism diagnosis, and to have time to practice functioning correctly while still like being who I am and not like cutting out that part of myself.
We all want the best for our children, and it is their path. It's not our path. So, you know, our job as parents and caregivers and medical professionals is to help them all find their best path. It is important to have support along the way because parents can't do it all.
And so that's the end of the presentation. I think the last slide is just like how to contact us or something, but happy to entertain any questions that you might
Okay,
have.
well, thank you very much, Dr. Ko, for actually giving us a little peek at the landscape of this condition, this identity. I want to thank one of our board members actually bringing this subject to us. Please give us the reference for, you could talk about early on the
Terminology,
identity.
no
duality,
problem.
yes, uh-huh.
Yeah.
I just have a couple comments because I'm sure there are members who want to ask questions or make comments. So I have one patient who is autistic. He's African American. He's a young adult. His mother is a single parent, and his diabetes, hypertension, elevated cholesterol, and he has some behavioral issues. And I remember when I first started being his doctor, because he's an adult, there were a lot of challenges, but I mean, he had specific challenges after all his diagnosis of diabetes, he was hypertensive, obesity, and that, and the behavioral issues that his mother always talked about. And so one of the things that I discovered early on, although I had to take care of his multiple medical conditions, I spent about a third of my time speaking to his mother and addressing her issues. She's not my patient. She's his mother. She's the mother of my patient. And so that when there was an issue with his managed Medi-Cal, I'm a managed Medi-Cal provider, and it got switched to another group, she fought to get back to me, and I think it's only because of the fact he may have had doctors who took care of her son, but just recognizing that there was a family to be taken care of here. So I think that this is something very, very important for us to see. My last comment is that I want to give a shout out the fact that that UCLA has in its curriculum and the medical students early on about how to be involved and take care of and recognize those with disabilities and other things that we need to recognize and really prioritize in an educational process. So are there other comments or questions from the members?
Could I respond to that?
Sure, please.
Yeah, so I just wanted to say, I do think that the intersection of race and autism is a challenge. So I do have families coming from South LA who come to see us with Medi-Cal, and it is much more difficult for them. And I think they come because it's hard to find a provider who treats them with respect and understands sort of the challenges that they have. To the point of, behavioral challenges, we do have a needle anxiety program that I had to start because we see so many neurodevelopmental patients. 10% of the population has needle anxiety, but it's probably 30 to 40% in my population. And I remember trying to get blood draws and vaccines on this population, and they wouldn't come. And the parents were like struggling. And it took me 2 years to get an ambulatory nursing protocol to be able to have us give intranasal Versed in our primary care office to be able to provide some procedural anxiety support. It took 2 years to get that approved. But everybody that I've talked to about this is like, wait a minute. Of course, because otherwise it was very undignified and unsafe for our patient to be told, oh, just take them to the main lab where there's like 6 or 7 phlebotomists and there'll be enough people to hold them down. Yeah. And that's not really dignified or safe. So, we've done these types of programs to be able to support the population.
Well, thank you. Dr. Ballant, yeah. Dr. Thorpe.
Yeah, Dr. Quo, thank you so much for the exceptional work that you do. And I know I've sent patients to Dr. Quo's LEN program. But if you could, because I think it's important, as you well know, we're looking at SVI4, right? Where do people live? What's the ethnicity? What's their race, ethnicity? And in your population, or just within what you've learned, can you talk to us just a little bit about how the populations break down? Because, we care for a lot of Medi-Cal, and we have largely Latinx populations. And it's what I find is really challenging, as you mentioned, there's only so much bandwidth all of us have, and your team is doing an awesome job. But when you get those Medi-Cal patients, by the time we see them, it's also the parents that have developed the severe anxiety. And it just, I'd like you to speak to that a little bit for the caregivers as well as the population breakdown. So thank you.
So actually in our LEN program at UCLA, we see a high proportion of Medi-Cal. We do have one limited Medi-Cal contract at UCLA Health with LA Care, and it was really designed for our Med-Peds population. It was designed for kids with special needs aging into adulthood. But because we're Med-Peds, we've been able to put all our sickle cell patients in there and a lot of our LEN patients. So we actually do have a high proportion of Medi-Cal kids. Many of them are from sort of not as much East LA, like a lot from the Inland Empire. I hate to say it. Like we have a number of kids driving to see us from Palm, like the Coachella Valley area. There's a bunch of cities out there. Palm Desert, not Palm Springs, I think. And then also Lancaster, Palmdale, like Santa Clarita, that area. We have a number of patients from northern part of the county. And so we've become aware, and I've been to IEP meetings in those school districts, and the ones in Santa Clarita and the northern part are not as bad, but the ones in the Inland Empire are particularly challenging, I will say, where, the administrators really just don't want to serve these kids, and we have to really be more forceful. And then as far as, what was the second part of the question? The social vulnerability?
Yeah, what I was talking about is breaking down the population in terms of, with your research, looking at different populations that are affected,
Yes.
Thanks.
Right. So obviously, from a national perspective, there is much more need among lower socially vulnerable populations because of access to not just primary care, but any kind of developmental service, which is why we have fought within UCLA Health to build our LEN team so that we have the social work team, we have a psychology team, we have psychiatric nurse practitioners because we could never get our kids in to see psychiatry. So then I became a preceptor for our nursing program, psychiatric nurse practitioner intern program. So we have some of those graduates with us, and we've been able to hire them. And so we're able through primary care to give the services to all the patients that need them, including those with Medi-Cal. And we also have Kaiser, I know we shouldn't say this, but we have Kaiser patients who pay cash to come see us just to be able to access some of those services. But I think every entity, like I would love to get into Kaiser and explain to them that it's actually cost saving if you do it this way instead of like try to do, a specialty program. But part of this is education and just making people aware that there's a different way that we can care for this population.
Thank you for your courageous advocacy, Dr. Quo.
Dr. Thorpe and then Ms. Lubiana.
Thank you, Mr. Chair. Thank you, Dr. Quo, for this great presentation. I'd like to speak to the comment that was made by the mother, who was an internal medicine doctor, Dr. Chang.
Yes.
And I think she hits on something that's really difficult, because so many times people go into medicine for reasons that are, we go into medicine for all kinds of reasons, right? But that idea of being there to take care of a lot of different people, and I'm a general internist in a rural community in Northern California, so I've practiced for 40 years and have, as many of us have, not many of us have practiced all that long, but the point is many of us have done primary, some of us did in primary care. And what you recognize after you've done it for a while is it's difficult to train doctors. And I would just ask, my question really is, as an educator, as someone who is in the trenches teaching young doctors how to think and how to work and how to manage their patients and all these things, how do we teach doctors to have that kind of spirit?
Yeah, I would say that is, we have a clash right now. I will say, because I was a residency program director and I still am for one of our smaller programs, we are coming up against the need to recognize wellness in our students with empathy for special needs populations. And ironically, I feel like our students and residents are very energized around social justice. So when I present the statistic that this is a health disparities issue, this is, shortened life expectancy because these patients aren't getting a fair shake in our system, they're all about that. But I will say when I precept in clinic and a patient is late, they are being taught to say, well, it shouldn't be my fault that the patient is late. I shouldn't have to stay later because the patient is late. So then they compromise and say, okay, we'll see the patient, but the patient can only address one issue. The first time I heard that, I have to say, I was a little taken aback, but that's what they were told centrally to say because they shouldn't have to accommodate late patients. I don't know what to do with this. Do I have some concerns for the future of our workforce? Maybe a little bit. But then again, the wellness issues are real. Like when I go back to my slide of protective and risk factors, and this is just me, my opinion, but the students coming in are less resilient and have different expectations of the profession than we did or when I trained 30 years ago. So, I respect that that's what they're being taught and this is what they need, but, when Dr. Chang is saying you don't know what that family has gone through to get to your clinic, and maybe that made them 20 minutes late, to be met with a resident who's like, peace out, not my problem, it's a little tough. It really is. So how many times has it been that we at the attendings are sort of staying late because the residents have all left? It's happening. So I share your concern or recognize that issue.
Ms. Lubiana, Dr. Mahmood, and then Dr. Yip.
Thank you. Phenomenal work and really eye and mind-opening presentation. I really appreciate all the work you're doing. This is really neat for not only to help those kids or their families, but society. Many of them can be so much phenomenal people and help not only in making new inventions and helping the other community who will be with that, because they'll be the best surrogates and best teachers for the future coming those people. What I was thinking is there a way to have some curriculum that in prenatal training for both parents about this particular subject for like an hour, 2 hours? The reason is that when parents or mother or father go to PCP's office after the child is born, everything is so busy. They have like 10-minute slot. They cannot discuss everything. But if they know the parameters, and they know what they expect from the child, because there is so much pressure on the culture, on the society. Oh, kids is okay. He's going to start speaking. He's going to start walking. This is no problem. And by that time, we are so late to get that. So if we can really embed, and I would take that medical board should take really a step on that, to put some kind of teaching, like 2-hour teaching, when they have prenatal, when parents, especially at the first child, to have the teaching that, okay, these are the things you need to be looking at your child, and everybody, not like, okay, it's people who are at risk, everybody. So that probably might help to get more early diagnosis, more early intervention, and get some better results.
Yeah, that's a really great idea. It's a good thought. The CDC has a program called Learn the Signs, Act Early that was originally geared towards primary care providers, pediatricians, but it's available, and many communities have adopted that strategy to educate the general public. I think it's a little tough to require that any couple, who's pregnant or thinking about getting pregnant do any specific training. More importantly, I think, is that pediatrics has to be responsive to questions and be vigilant, right? So we have this concept of developmental surveillance that the American Academy of Pediatrics has put into place since, the early 2000s, maybe 2006. But realistically, we also know that 30 to 40% of pediatricians don't do it because they don't have enough time, because the well-child visit has gotten shorter and shorter. 20 years ago, it was 20 minutes, and now it's almost like 12 minutes. So in 12 minutes, you really can't engage in this conversation. At UCLA, I have fought, and we've been successful, that in med peds, our well-child visits are 30 minutes. Because then you can have these conversations and you don't need to refer to a specialist because you actually have the time to engage. And so I think that those types of interventions probably makes a lot more sense, because even if you were to train the parents before they had the baby, they're not going to remember. They're just not going to remember. And so it's when a question comes up, grandma's like, I don't know, then they want to come into the pediatrician. It's like, somebody said, can you check him out? And so I have had many worried come in because they know I'm an autism expert, and they're, I'm worried about it. I said, okay, let's check it out. And the kid is doing fine. I said, duly noted, I'll make a note. Come back when there's a problem, right? I think we're good for now. Everything is doing well, but that's that monitoring, that's the surveillance that needs to happen. And then parents are like, okay, had a conversation with the doctor, everything's okay for now. If anything happens again, come in. Pediatricians are cheap. Well-child visit, 99213, that's not expensive when you look at the whole scheme of chronic disease management and mental health services. So that access for families, I think, is very cost-effective.
Ms. Lubiana, and then Dr. Yip.
Thank you, Doc, for your time and presentation and all of your work. I appreciate one of the slides where you showed that 72% of the patients are adults. And my impression is that once they are adults, the amount of free or reduced price services are much less. And so for thinking about healthcare and physicians, how can their care dovetail into what services are actually available for them?
Sure. So, this is why I do give presentations to internal medicine residents because, as we mentioned, they do grow into adulthood. The statistics show that only about 70% of autistic youth without an intellectual disability go to college, go to post-secondary education, and most of that, upwards of 80%, are in a community college. So once you lose the support of the K through 12 system where there are, special education services to help and moderate, then we're talking about what I call launching, right? Are they truly independent? Are they really able to navigate a college campus by themselves, without their parent taking them and things like that? And so if I get kids young enough that we can say that's a goal, we can orient the entire family around preparing that child for that adult independent living. Because if you've, again, had children, it's not like all of a sudden at age 16, you're like, oh, you're about to leave the house in 2 years. Let's get you all ready to go. You're building that block, like from the time that, at 10 years of age, they learn how to make their own food. At, 12 years of age, maybe you teach them how to do laundry. It's a whole process. And so my goal is to optimize as many children as possible so that in adulthood they can function without needing services. I think the challenge with a service-oriented model is that that's very deficit, and there will never be enough money for all the services that people need. And so the better strategy, again, as a preventive medicine physician, is to optimize so that they can arrive at adulthood with minimal support. Not necessarily a program, but maybe an employer, like being more discerning about the type of employment that they seek, making sure that there's better benefits or whatever. Like we get into a lot of conversations, but once we're in the adult space, it is very uniquely tailored to each individual person because there's so many different kinds of adults, right? All kids go to school, so our focus in childhood is really school. But then in adulthood, we have them, the ones that want to be animators, and they're not really comfortable in a structured school setting, and so they're developing portfolios on their own. It's just like a whole gamut. I've learned so much about all different opportunities. Kids that want to go into automotive, and so we do research, and we're like, oh, okay, and then we ask, what resources are available that are in just the general population available for everyone. Because again, if we funnel everyone through vocational rehab, like that is a limited resource, and again, there would never be enough money.
Thank you.
So is Dr. Yip the last member? Oh, and then Dr. Tsai.
Do you or your team use telehealth as well, like follow-up, spend 15, 30 minutes, your PA, MP, catch up with the patient who travel far away?
Oh, so the way that our clinic model, I think you're asking about our clinic model. So I am a primary care provider, so I do follow some patients myself. I'm sort of full, so what we've done is as soon as the wait list gets too great, because I said we had that commitment that we want to get any patient in within 2 months, I rope another faculty member to get trained. So we just continue to expand capacity, and there are patients for whom we are the primary care, but if they love their primary care provider, even within or without outside of the UCLA system, but their primary care provider just doesn't know that much about autism, we get a lot of those types of patients, then we say stay with your primary care provider for everything else and come to us when there are autism issues. Right? And then we try to educate the primary care provider. Like, we don't want to just inherit every patient. That would make us a bottleneck. So we want to be a layer on top of primary care that supports the primary care provider to care for this population. And we are there for when there's problems. Does that make sense?
Do you use telehealth as far as follow-up?
Yes. So telehealth has been great, actually, because number one, our families come from very far away sometimes. Secondly, sometimes if there are significant behavioral issues, it's a lot easier to let the child stay at home where all their play toys are and everything, and rather than displace them and come in. I do say for the patients with ADHD, I have to see them at least once a year to get a weight and manage their medication. But otherwise, everything else can be through telehealth because it's a lot easier for the families. and we also get an insight to what it looks like in the home. And sometimes you don't realize how chaotic things are at home until you like see it on the screen. And then that also gives us more, clues on how to help them.
Your work is admirable. I'd love to meet your team sometime. Thank you.
Sure.
Dr. Sai?
Yeah, I think comment/question. I think it's excellent that UCLA is doing this. Number one in the West, of course. One of the things is that I think it starts in medical school. It's very, very important because, as we all know, patients with autism need all sorts of services. It's not just limited to pediatricians and internists. I'm an ENT, and usually it's the 50-year-old bringing their 80-year-old parents to come see me. But patients with autism, it's the 70-year-old patients that's bringing their 50-year-old kid
Right.
to come see me.
Yes.
And eventually, these patients, if they don't get transitioned, they get institutionalized. And that's the horror, because all they know in their life is their parents. And now they're in a strange environment. And I think having doctors be aware, number one thing, but also having a system to support. I can know that these people need services, but where do I refer them to? UCLA. I'm in the 626. It's 30 miles away, and on a good day, it takes 2 hours. They're not going to be able to drive their kid 2 hours to UCLA. That's just a distance thing. And of course, insurance. If the insurance doesn't cover it, doesn't approve it, that's why you have Kaiser patients paying cash. So I think in a bigger picture, this is great, and we need to look at the model and sort of promulgate it across the entire state so that California is not just sort of saying, okay, autism awareness. Now we're accepting it and we're providing the structure to help these patients. I think that's the bigger picture that I got. So thank you very much.
Absolutely. Thank you. What I will say is that I think the reason that I came up with healthcare system being where the adults are cared for, because obviously in the K through 12 system, that's a big place. But there is no equivalent of the K through 12 system for adults. And the only system that all adults all encounter is the health system. So I think we do have to take that responsibility for adults. But again, to your point, I do a lot of future planning for my adult patients because their parents are like, my plan is to never get sick. And I'm like, I hate to say it, the one certainty in life is that we all die. And so that's not gonna work. Who is gonna take care of your intellectually disabled child when you are not around anymore? And there are some families where there's literally no one. So then we start to say, let's plan. What are you going to check out group homes? Are we going to work with regional center? Like, we have to prompt them, because what you don't want is the family that didn't plan, just thought they were going to live forever. And we know during the pandemic that lots of people, did not survive and leave their child in this situation. So as the primary care provider with that relationship, we can broker that conversation very gently, 10 years in advance, right? Not 2 years in advance. Like, we need to be planning about this. And I think parents have that in the back of their minds. And I have had so many parents thank me for actually talking about it because they've been worried about that. They just didn't know where to get started. So, yeah.
Well, Dr. Quo, thank you for your leadership and all you do.
Yeah. Thank you.
Thank you.
Thank you for having me.
Yeah. Are there questions and comments from the room? Please come forward.
Good morning. I'm Chaplain Reverend Queenie Ruth Summers Tweedle, and I wanted to give some information about a resource. And thank you so much, Dr. Quo, because in the early 1990s, I was working with differently able youth at a college as a professor. And we had persons that came in that were quadriplegic and autistic. And I'll give you for instance, like one young man, I won't call his name, bless his heart, when we gave him the knowledge that through our theater programming that he was a wonderful person to look at. We would tell them to think about something good to eat and take a picture instead of telling them to say cheese, because cheese is a grimace. He looked at the picture and he said, I look like that? And we said, yes. After that, he started asking people to go out with him. And he would be in that chair, he put his hand up, and that meant he wanted to dance, and people would come over and hold his hand and dance with him. Now, the point I'm making here is that a portion, and then there's another young man I'm thinking of, got started working at a grocery store. When he first got there, he looked a little, shall we say, different. At this point, after about 12 years, he is spiffy, he gets those carts back, he knows exactly what to do, he is on punch, on key, but he was trained to actually appreciate himself. And so we have a program, Rap to Tap Performance Camp, that we do that basically we can take children that are reading on third grade level, second, third grade level, and bring them in a space of 4 weeks to 11.0 plus. And so we just want to make sure that people are aware that there are different things that can be done. And along with that, Dr. Sue Maraska, I'm still in touch with her. When I go into Houston with me, and I stay at her house, So if we could get maybe some of the people to work together in the different programs, but then we could end up having things where people will be doing things on a different level and appreciate that they are differently able as everybody else appreciates that they are differently able, not disabled. Because when you think about it, the word dis means when you're dissing somebody, you're setting them to the side. But when they're differently able, you are appreciating their differences. So enough of me already. That's enough from Grandma for today.
Thank you very much.
Love everybody.
Others in the room, comments? WebEx, oh yes, I'm sorry. Please come forward.
Hi, my name is Lucas Evanson, speaking on behalf of myself and not my organization. First, I'd like to thank Dr. Quo for the discussion at the beginning of the presentation on definitions and language. I think it continues to show that language is evolving, and my takeaway was just that we need to listen to what people want and be considerate of how they would prefer to be referred to, which is great. I did have a question, though, that hopefully Dr. Quo could answer after the public comment. When Grayson was speaking in the video, something struck me. They said that the diagnosis was liberating, and the name of the presentation is Identity, Not Disease. And in my mind, I have a very narrow definition of diagnosis, which is, you diagnose a problem or you diagnose an illness or a disease. But in this case, I think if we reconciled the two ideas, we would be having physicians diagnose identities. So I was wondering if Dr. Quo could sort of steer my brain and my curiosity in this situation. Should we be rethinking diagnosis and expanding how we think about, or maybe I just need to expand how I think about diagnosis, or should autism not be diagnosed? My only thought about that was Grayson appreciated the diagnosis. So I'm just, sparked some curiosity and was hoping that Dr. Quo could speak to it. Thank you.
Other comments from those in the room?
I would just like to say we are very, very grateful to have her and her commitment to that group of people, because they're ignored, we just don't pay attention. But the other thing that we have to remember is what she said. When she went into medicine 30 years ago, she was motivated by certain motivations. Today, one of the most severe obstacles to people going into medicine is the cost. Consider what it cost 30 years ago and what it costs today. And it's very difficult for people to want to serve others and be strapped with a burden of having to pay back or pay what it costs to go to medical school. I'll give you an example. I had a friend and his son got a scholarship to Harvard Medical School, and his dad had a chance for an advancement in his job, and his son told him, "Please don't do that, Dad. Your income then would put it to the point where I wouldn't be able to continue with my scholarship and wouldn't be able to go to school." That is unconscionable in our country, and we, I don't care about the rest of the country, but we as a state have got to really start looking at what it means and how much it costs and what the consequences of those costs are to us as people in California and the impacts it's going to have on our health care. We've already seen it today. We don't have enough doctors and we don't have enough nurses. And we really need to start thinking, you're the medical board. You see it. You're doctors. You know what it costs to get to school. You need to look at those things, and you need to come up with a way of talking to the state. And I know the military has the aspect where if you go in, they pay for your education, but you have to commit so many years of service. We need to do something. In Europe, people can go and become doctors and not be strapped with the kind of situations that we have. We have really got to take a look at that and consider what options we have to consider in order to get more people into the professions and not be strapped with such debt. We owe a great deal of gratitude to the people that commit themselves to go into medicine, and the least we can do is help them get there. Thank you.
Thank you very much. Others in the room? WebEx?
For individuals wishing to make a public or the Q&A window in order. And if you're on the only line, you can press star. First up here, we have Eric Andrews. Eric, should be receiving that prompt.
Hello?
Good morning, Eric. Your line's open.
Okay. You know that I'm one of those family members who cared full-time for my mentally retarded sister, Callie, after our mother died, until she was killed by medical errors and a horrible doctor, for which this board did nothing and closed my complaint. But I wanted to call in and say this is bigger than just a simple with any kind of disability. Here's an example to take my person as simple as a mammogram. It's unnerving as a male taking a woman for a mammogram and insisting on seeing with her. My sister has a mentality of a fool.
I'm sorry. The feeding in the room is glitching out. I think I'm about this. We'll go ahead and reset the time so as well and improve the bandwidth. Okay, Eric, I'm going to get you restarted your Windows. Are you still with us, Eric?
I'm here.
Okay, please, we'll start your time. Thank you very much.
Did you hear any of what I said, or should I restart?
Please start from the beginning, yes.
Okay, from the beginning. Some of you know that I'm one of those family members who cared full-time for my mentally retarded sister, Callie, after our mother died, until she was killed by medical errors and a horrible doctor, for which this board did nothing and closed my complaint. But I wanted to call in and say that this issue is bigger than just people with autism. This can be broadened to include people with any kind of a disability. Here's an example of what it was like for me to take my sister in for something as simple as a mammogram. First, it was unnerving as a male taking an adult woman in for a mammogram and insisting on staying with her. My sister had the mentality of a 4-year-old, and I don't think anyone would leave a 4-year-old child with strangers, especially if she had to remove her clothes and reveal a 58-year-old woman's body. So I would always call the office ahead of time and remind them that I was bringing her in and had to stay with her. Invariably, we'd get there and no notations had been made in her file, and the staff would create a very public hullabaloo over me being in an area where women were having mammograms. Other times I'd take her in for a surgery or something and they'd make me leave the room when they did anything to her at her bedside. I told them I wasn't leaving, that I was her caregiver. They would insist and I'd have to insist back, and many times had to call for the hospital patient's ombudsman for help. They'd say, "You can't see her naked." I'd say, "Oh, do you think I wear a blindfold when I bathe her or when I wipe her rear end?" Then they'd shut up. It would run the gamut from a doctor who would sit and ask very complicated medical questions of her, and when she would answer back, she wouldn't answer and look at me confused and ask if she could speak. I would ask if they read her file before they came in to see that she is mentally retarded, and clearly they hadn't. Or they'd assume she was mentally retarded and not look at her at all and treat her like she was a deaf mute. There was rarely any in between. It was astonishing to me how uncaring doctors could be in the situation. Her medical records after she was killed by the doctor listed the fact that she was mentally retarded 24 times in the records, as though that was the cause of her being in the hospital, and yet they still didn't know how to behave around her. On the flip side, my roommate, a veteran who has also filed a medical board complaint that was closed without helping him, suffers from severe depression. That's notated in his VA medical records, which every doctor sees and can see right off the bat. That stigmatizes his care, and I can't tell you how many times they have dismissed his symptoms, simply alleging that he's making them up as part of his depression. It takes referrals from multiple second opinions before we can finally get someone to admit that he's not making anything up. It's just easier for the VA to prescribe him something and dope him up. Recently, he attempted suicide, and even after the VA found out about it, they continued to issue him medications he took, one of which he now has nearly 500 tablets of. Autistic, mentally retarded, someone with depression, the elderly, or just someone in a wheelchair often get treated differently and not necessarily in a good way. Last paragraph. These kinds of things should be taught in medical school. How to deal with people that are different in any way, and how to decipher what could be wrong with someone when they can't readily explain them for themselves what actually is wrong. Thank you.
Thank you for your public comment. Next up here we have Rosie Arthur's daughter. Rosie, you should be receiving that prompt.
3 minutes, of course, is not going to be enough. Some of my history, as I've told you before, I was earlier in life a forensic neuropsychologist. And while I was in my internship in a forensic setting, I began to encounter a good number of persons with symptoms and odd behaviors, and they'd been evaluated numerous times, and nobody seemed to know what was wrong. And at that point in time, while we had, in the DSM, we had Asperger's, it only applied to children. It was a disorder of childhood. And as I made my evaluations, I came across a number of issues. Some of these things have been discussed, such as the reading the rules but not knowing how to apply it to processing environmental information. But it didn't apply to adults. I worked with adults, and it was thought that it just went away. Well, of course it didn't. So you now have huge populations of adults that have these problems. You have children who are being diagnosed, and there's a high probability that at least one of their parents may have similar traits, or is a mentor, serves as a mentor or a collaborator to get things done. So your family systems are very, very closed. The use of pronouns, I'm not talking about gender-specific pronouns, but the ones that, me, you, that use of pronouns you will find is very blurred when you're encountering persons on the spectrum. And oftentimes, to function, to get through life, they will appropriate other persons' experiences. They will confabulate, and they don't know how to apply the rules to themselves. Finding their gifts is difficult. They need structure. And so many things apply to
30 seconds.
their environment and their family and social structures. So I had the first successful SSDI application for a person with Asperger's who was 50 years old, had no other disabling conditions in the country.
Please conclude.
So this by Social Security. So we've come a long way, but there are programs for adults, and I think we need to make sure that there's more community access for adults.
Please conclude, Rosie.
Thank you.
Thank you very much. At this time, Dr. Hawkins, I don't see any additional requests.
Very good. And thank you again, Dr. Kwan. Moving on to agenda item 11, final report on the enforcement monitor, Mr. Les Lombardo. Welcome, sir.
Good morning, all.
Morning.
I first want to sincerely apologize for not making this presentation on December 1st. For the first time in 4 years, we were able to bring all of the kids, the young adults, back home over the extended Thanksgiving holidays. And a result of that week-long family gathering resulted in COVID, RSV, and a few other illnesses, so I was in no shape to publicly speak. And I think, Reggie, I think I sent you an email like 36 hours before, so I sincerely apologize. But we're ready to go today. This, we have a PowerPoint, a slide deck, and it's going to capture our final report findings.
Les,
And Sean, you're going to drive.
can you bring the microphone?
Like this? Okay. Okay, next slide. Okay. Section 1, CCU complaints. What we specifically did here was we looked at complaints that were filed resulting in death complaints that did not result in a referral for investigation. Okay? We selected, over a 6-year period, we specifically selected cases that fit this attribute. There were 37 cases selected, and we were able to review 19 of them. 18 of the cases, the records were not available because there's only a 1-year record retention protocol. So what we found with the 19 that we were able to review is that all the protocols and procedures were in fact followed. There were detailed records capturing what was done, to the extent that records needed to be secured, releases need to be secured, all those protocols, everything was documented. The medical consultant evaluation or evaluations, everything was documented. And so we were satisfied that processes and procedures, the protocols were in fact followed, right? What, excuse me, what we are recommending is that that the 1-year retention policy, and Sean, next slide, please. But the 1-year retention policy is insufficient, and here are our 3 recommendations. To document what in fact was done, okay? In other words, to the extent that the records aren't available, we can't document or prove what did in fact occur, okay? And especially with these types of complaints that resulted essentially in death, serious injury or death, we feel it's important to maintain the necessary records so things can be evaluated, okay? We as an addendum to that, we would like to see, to the extent that imaging can be employed, right? Because that's where the technology is going. The adoption of imaging so that can be maintained securely, providing anyone that needs to review these complaints and the aftermath, they're available. We understand, we've talked with your IT folks, with Sean, et cetera, that the current case management system, Breeze, has certain limitations on the ability to capture and store large amounts of data. Okay? Questions?
Imaging means to put it in a file that's easily retrievable?
Exactly. Scan, image. The file room over at Evergreen, I mean, it's massive, and your people do a good job. However, only half the files were available because when you establish record retention policies, and this is a legal issue, those have to be followed pretty precisely. You don't want to maintain records where your record retention policy says we're no longer required to retain these. So, item number 2, so we review the complaint tracking system, and in talking with Carrie and Sean this morning, this is essentially resolved. What our issue, when we looked at this, so there's a system development life cycle, a protocol for developing such systems, and the department is following it. They're following the protocols. The key here, the key to this system, as well as systems analogous to this, is aligning system functionality, delivered functionality, with stakeholder expectations. And so in this particular case, there was solicitation from public stakeholders, a couple of public meetings, with a whole bunch of requests. we'd like this functionality, we'd like that functionality, a series of, quote, requirements. However, due to the confidentiality of this program and the ability to deliver, when we looked at this, a number of those requests, those requirements, had to be legally scrutinized. Our understanding, since this was published in August, is that has now been done, right? And you now have a minimum viable product that you're going to go forward with. And as long as that's communicated and aligned with stakeholder expectations, you should be okay. Okay. Next slide. Okay. So when in our first report, this was, we had three, there were four significant findings in our first report. Obviously, the inability to fund the operational program was the last of the four findings, and that has been addressed in this current legislation. But the first three were the inability to maintain a viable sworn investigative workforce over a period of years, which is an ongoing problem. The second was in 2018, the termination of VE. In other words, the collaboration between prosecutors and investigators. And what we documented in that first report was when that happened, and it actually the lack of collaboration actually started about in July of 2018. But in all the analysis, we noticed that the case referrals, in other words, actionable cases that were signed off by the chief of enforcement of the medical board and the chief investigator that went over to HQE over that period of time, they rose from about a 5% return or rejection to a 35%, a factor of 7. So one in excess of 1/3 of the cases by 21-22 were being.
Excuse me, Ms. Lobardo. HQE refers to Office of the Attorney Generals?
Correct.
Thank you.
The prosecutors at the Attorney General. Okay. So this substantial increase, right? And so in this evaluation, we went under the hood. We took a look at 50 cases to determine, and it's extensively documented in our report, to determine what's causing this problem. And they fall, the deficiencies in the referred cases fall essentially into two buckets. Evidential matter or problems with the medical expert reports. We're essentially now, for the last 4 years, we're essentially operating under the handoff model, right? And in our first report, this business model, along with similar other business models, in order to get efficient, effective, and timely adjudication of these types of cases, require collaboration and what we call contemporaneous collaboration. In other words, from day one, you have to work together. We've got these three distinct disciplines: medical doctors, medical experts. A case can't go anywhere without the medical expert evaluation. The investigation aspect of the case and all the things that are required in putting a case together. And then the prosecutors' ability to build the case relative to evidential standards, legal standards, etc., that cannot be done in isolation. And what we found over these 4 years with a rejection or return for supplemental investigation corroborates that the handoff model is inefficient, very ineffective, and doesn't produce timely results. In this examination of these 50 cases, we found that cases were taking 3, 4, and 5 years, requiring, in some cases, a second, a third, or even a fourth supplemental investigation. In other words, it's just bouncing back and forth. That's not consistent with the goals and objectives of the program. So our recommendations are the program has to return to a collaborative effort between investigation and prosecution. And our first recommendation is keep the existing order, MBC, HQIU, sworn investigators over at DOI, and prosecutors over at the Attorney General's office, and enter into a contract, what the state refers to as a formal memorandum of understanding, documenting all the roles, responsibilities, everything that will make this happen. But that contract will be approved and governed by the board, or by MBC, the operational aspect of MBC. Without that, we believe that the results of cases are going to continue down this path. Especially when you look at, sworn investigators, when you look over our initial analysis, right? We looked at an 8-year period. Actually, we looked at 98 months, right? 2016 through 2022, right? And HQIU, right, when it was established in 2014, but over the 8-year period, there were 111 separations. In other words, 111 investigators left and 111 were hired. And I think there's only 103 established positions. Constant turnover, and we were told, and we have this documented by the program people, it takes approximately 5 years to become seasoned as an investigator in medical investigations. As the 2004-2005 monitor, Felmeth and Papa George, extensively documented in their 2-year review, right? Medical investigations are quite complex. There's many interactive and dynamic parts, and you need investigators and prosecutors to work together in distilling all the information and building the case, because ultimately it's the prosecutor and only the prosecutor that will be given the case to make that determination of what are we going to do. We're going to file an accusation. Once the accusation is filed, how are we going to handle it, right? Will we go to a full hearing? Will we stipulate, et cetera, et cetera? Well, what we're seeing now after the end of VE is the prosecutor, when the case is referred over, the prosecutor is seeing it for the first time. And so they go through a whole triage process when handed this case, just like CCU at NBC does when the complaint first comes in the door. There's a whole triage process. Analysts, medical consultants working it all up. And so it's just, it just extracts everything, and then certain needs of the prosecutor are not met, so the case is either just outright rejected or it's returned with a detailed list, when you read our report, a detailed list of deficiencies that have to be mitigated. Well, all that takes time. And it jeopardizes the case because sometimes 2 or 3 years later, a key witness is no longer available. So, enter into a structured contract, an MOU, with everything identified, who's responsible for what, accountability, responsibility, etc. Okay? And we're strongly recommending that an independent facilitator specializing in doing this be brought in to assist, especially if you're going to go down the road of not keeping the organizations as they are, but think about organizational restructuring. So in 2006, based on the 04 and 05 monitors report, VE came into existence, replacing previously from 96 to 05 what was ditto, DAG and district office. And there was a prosecutor put into the NBC investigative offices, some 13 offices. So, right, but that went away. VE came in, and in 2010 there was assessment. There were problems with that. In 2006, before VE was established, up until the 11th hour, NBC sworn investigators were going over to DOJ, and at the last minute, the sworn investigators were maintained at NBC, and VE came into existence. In 2014, this was all revisited, and again, up until the 11th hour, the sworn NBC investigators were going over to DOJ a second time. And at the last minute, the investigators were not directed to DOJ, but they were taken out of NBC and they were put into Division of Investigation over at Consumer Affairs, but a brand new unit. So DOI's been around, I think, since '61, a long time, but a brand new unit was stood up strictly for medical investigations, HQIU. And then in 2017, 2018, over that 2-year period, the great debate occurred. Should we continue and refine VE, or should we terminate it? And ultimately, it was terminated. Okay? Collaborative effort stopped, and we have the situation before us. So, if you're thinking about going down the path of, again, reorganizing where these key players should reside, should Investigators, for example, come back under the board. We believe that you need to bring someone in, a facilitator that really specializes in this, to identify all those key issues, right, that will help you reach a desired, viable outcome. We strongly suggest you cannot stay with the handoff model and meet your obligation to effectively, efficiently, and timely adjudicate, thereby protecting the public. Right? I mean, I've been licensed by the State Board of Accountancy for 4 decades now, okay? So if a complaint were filed against me, I'd want to know that, right? I'd want to know that, and I'd want my case timely evaluated, and if I'm at fault, I want to know that so that I can take the corresponding mitigating actions as a professional to meet my standards. But at the same time, if the complaint is not valid, then I also want that cleared up as well. So I guess what I'm saying is all parties, all stakeholders, whether it's doctors, the complainant, the patient advocates, all parties involved want effective and timely outcomes. And the handoff model will not achieve that. Questions?
To the end.
Okay. Next slide. And this slide just says what I talked about. So if you can't achieve keeping everything in place and working out a legal structured agreement, i.e. a contract, an MOU, then there are these other avenues to consider. Okay? And then item 2.1.3, okay? So during our engagement, we secured a number of artifacts and we talked to a wide variety of people throughout NBC and throughout HQIU. And specifically with regard to 2.1.3, so there are very, very seasoned investigators, medical investigators, sworn investigators who have been doing this for 15, 20, 25 years that have real experience, right? And what they pointed out was since the termination of collaboration, investigators are excluded from the process, from being heard. And so they gave us, the investigators they gave us 16 cases that in their professional opinion, 9 cases that were referred that were not pursued through accusation. The accusation didn't happen. And 7 cases where the accusation went forward, but the discipline that was imposed, the investigators believe that because they were not heard, the the effective outcome was not achieved. In other words, cases that were not filed, that should have been filed, or disciplines that were imposed that were not imposed to the extent they should be imposed.
I'm going to resist the temptation to interrupt you, but who would have heard what the investigators would have reported to? They were not heard by whom?
By the Attorney General.
Not internal to the investigation unit.
Correct.
Thank you. Okay, thank you.
Yes. So we wanted to point out that so you have these different disciplines. You have medical experts, you have investigators, and you have prosecutors. And obviously, these folks have strong opinions, right? And they've been doing this for quite a while. Well, when you bring those people together and you distill all of the multidimensional aspects of a case, decision makers are better informed. And the reason this is in here is they believe that because they were not heard, decision makers weren't completely informed, and the right decision wasn't made. And so as we follow our standards in doing these reviews, so this was a material item in the conduct of this review, right? And so we believe we had to report on this. We are not attorneys, and like we put in our report, we are not attorneys, so we could never, ever second guess what the determination by HQE, by the prosecutors, was, okay? What we're saying is, by not having this collaborative effort where all parties are engaged, so all aspects of a case could be heard, maybe different outcomes would have been achieved. That's something we won't know. But we thought it was because your sworn investigators felt this was material and it was brought to our attention that we had to bring it to your attention. Okay? Next slide. Okay, this was thoroughly documented in our first report. And as you saw, of the 32 disciplines, there were about up to 11 of the disciplines that either always had critical shortages or periodically had critical shortages. Without the medical expert analysis, a case cannot move forward. Okay? So, we wanted to talk to at least a half a dozen practicing doctors, and we were able to talk to 3. And they were very informative discussions, what they had to say. So in putting our recommendations together, recruiting is a real key aspect of ensuring that you have the necessary medical skill sets within the program to evaluate these standard of care cases. And so what they were saying is person-to-person contact, whether it's in-person recruiting or virtually, makes a significant difference as to whether or not you could achieve more viable participation. All the public, the emails and all the notifications provide information, but it's when you have that person-to-person contact, right? Program people and doctors talking to other doctors, really giving them the importance of what this program is all about and why it's needed, you get there's a potential for a higher degree of participation. Okay? Currently, there was a two-tier pricing structure, whether or not the medical experts that are currently retained, if you go through the training, you get paid at $200 an hour. If you don't go through the training, you get paid at $150 an hour. And we're saying eliminate all of that. Okay? Go to a single pricing structure, all training. In other words, everyone has to go through the training. And 2.4, the compensation has to be increased to the level of expertise that we're talking about. I mean, doctors shared with us routinely for comparable consulting engagements, hourly fees can range from $400 to $800 an hour, $400 to $800 an hour. Okay, and they also shared, since we only have, a little amount of time to participate in this, because we have our practices to maintain, etc., that while the compensation wasn't the overall driving attribute, it certainly was a consideration. If I have 7 hours available during the month to go consult at $800 an hour, why would I accept $200 an hour? Okay? Then the final one, which is 2.2.5, and again, this was the 3 individuals we talked to, and then other research as well. Because this is so absolutely critical to operating this program, you can't function without a medical expert evaluation in adjudicating these complaints. Would it be required participation when holding the license, that if called upon to serve, you would serve? Now, I understand that in talking with Carrie and others, that right? I mean, that's kind of out there. But it was actually all 3 of these MDs that we talked to said, in order to maintain the viability and integrity of licensed physicians and surgeons, maybe that's something we have to do. Next slide. Okay, so this was relative to 2229, the guidelines. Okay? And the application of guidelines of disciplines relative to violations. Okay. So every government program has regulations. They are the defining criteria relative to government programs is what you can and cannot do. Right? Yours are guidelines, they're regulations, right? And your guidelines actually are very detailed, right? They run somewhere in the neighborhood of the guidelines themselves relative to the application of guidelines against identified violations. I mean, they run 12 or 14 pages. For this violation, there's a minimum and a maximum guideline. For the next violation, there's a minimum and a maximum, right? But 2229 and the guidelines also allow for departures, deviations, when there are mitigating circumstances, otherwise known as justified departures. Okay? So we pulled the sample, we went through them all, and so there's 3 outcomes that could occur, right? There was a noted violation, and the guideline was applied, the discipline was applied relative to the guideline. So the discipline applied was in accordance with the guideline. The next case could be the noted violation, the identified discipline within the low to high range. However, the discipline imposed was not in accordance with the guidelines. It deviated, but it was a justified deviation for mitigating circumstances, and those mitigating circumstances were documented in the file. The third type of outcome could be that the violation was noted, the discipline was imposed, it wasn't imposed according to the guidelines, and there was no justified mitigation. So in other words, it was a true departure from the guidelines. Those are the 3 conditions. In our sample, we never found a imposed discipline outside a non-justified imposed discipline. They were either imposed per the guidelines or there were deviations. Now, the deviations, so in our sample, there were more justified deviations from specified guidelines than there were for the application of discipline within the guidelines. In other words, there were more departures. The problem is you're not allowed to disclose the mitigating circumstances. And so what we're concerned about, especially when we've evaluated other programs throughout the state that operate outside of their sanctions, of their guidelines, of their regulations, of their policies and procedures, and you can't determine why, it puts doubt in the public's mind. So what we found was, in this evaluation, was you operated within 2229 and the guidelines. But the majority of the cases were deviations, justified deviations, but you can't tell why. And so, a lot of the feedback we heard, that puts doubt in stakeholders' minds, because back to bullet 1, the key here, guidelines help ensure uniformity, certainty, and fairness in the enforcement program. And so it puts doubt. So we're saying get the team of right people together, which would obviously include the legal side of the house in terms of, well, if we were to modify or reform these guidelines, what could what could we do and what can we not do, right, to restructure, again, to ensure uniformity, certainty, and fairness. And that's beyond our scope of expertise. Okay? Next slide. Okay. So this was actually some interesting analysis, and it's all in our section 3 in the report. You'll see all the tables, but we essentially had 3 data sets to work with, and unfortunately, we only had the data, okay? We had licensees, approximately, 160,000 licensees with self-identified race, ethnicity designations, and it was about 82% of your population had designated race, ethnicity. Then we had the physician surgeon licensee complaint database, so we had all that data. And then we had the physician surgeon discipline data, right? And we took the data and we took the pro rata, the percentages by ethnicity of the licensee database versus the physicians and surgeons where complaints were filed, again, by race, ethnicity, those proportions, and then also the discipline data, those were actually disciplined, and we built those tables, right? And we showed the comparative difference. And to the extent in any one of those tables, when we were comparing the percentage of licensees, so 2.3% of all licensees were of this particular ethnicity. 3.4% were of this particular, right? And then of the second group, so of those physicians and surgeons who had complaints filed against them, we did the same thing. What percentage by race, ethnicity were they relative to the total population of complaints filed? And then for the third, okay, for the discipline imposed for that universe, what percentage of each group? And then we did the comparative analysis. And to the extent in the table where you came up with a positive percent factor greater, right, it showed that this particular race, ethnicity, licensee race, ethnicity, had more complaints filed than the standard, or more disciplines imposed than the standard. But this was just data analysis. When you look at to really determine, is there bias imposed, you have to go back to what CBR, California State Library, Patrick, the 10-year study. There's just a multitude of variables that have to be considered in doing this type of analysis. And I believe you actually have to go into the associated records, and you really have to understand, you have to pull a representative sample, but you have to go into the weeds and understand what happened, what triggered the complaint, you know, what were all the things during the adjudication process of the complaint, the outcome, and then the imposed discipline. Looking at just the numbers, just the data, it gives you some indication, right? But it doesn't provide much more definitive analysis. And the last study that was done, that 10-year study, I mean, the author concluded, right? The conclusion was, right? I can make no determination as to whether or not bias exists. What we would like to see, so we built this whole data set. We built all these protocols, you know, for comparative analysis, and we're willing to share our methodology of doing this. We will turn it over to your program folks and your IT folks and say, run with this and expand on it, because it now gives you a basis for at least publishing information. Even though, in other words, you can't make a definitive formulation from it, is there or is there not bias, but it gives you some insight as to trends and analysis. And last slide. And at the time, as of August, there were these two issues. So in our first report, that finding number 4, we did a 26-year analysis relative to the funding of this critical program, right? And there were, over 26 years, dating back, I believe, to 1996, there were, because the program is subsidized through licensing fees, right? So in that analysis, and I shared this with you in our first briefing, there were three fee increases that were very, very small over that 26-year period. And when I briefed the last time, I said, you know, if we were CPAs in here doing a financial statement audit of the medical board, and that was not what this review was, but if we were doing an attestation audit, right, we would label you, you're not a going concern. You can't maintain program operations without the funding, and we probably would have given you an adverse opinion. Now, because in those 3 previous periods, you went in for an ask, and you went in for an ask of this much, and you received this much.
All right, Les, can I ask you to hold on a sec? This is disconnecting me again. Give me just 1 second to get this. Get everyone back online. I'm sorry.
At Chairman's prerogative, we're going to take a bow break after the presentation, and then we'll return after your last slide.
meeting is being recorded.
Okay, let's get back online. Sorry about that. Take me a minute to get back up.
We're good to go?
We're back online.
Okay. So, we haven't done any substantive work after the August 18th submission of the report. But we did hear that your request for increased licensing fees was in fact granted, approved, right? And starting January, you will be getting a significant licensing fee increase, certainly significant compared to the last 26 years. So we were happy to see that happen. Okay. And then there was the CCU complaint outreach legislation that was going forward. We're assuming that you're going forward with that, and there's procedures and protocols being enacted.
Yes.
Okay.
Is that the end of your presentation?
That concludes the presentation.
So what I'd like to do first, we could take a 15-minute bio break. I welcome Dr. Dingra, new member. And there's a lot to unpack, which I don't think can't possibly do here today. But I think we should focus, to the members, we should focus on 2.1, which is a big elephant in the room, and ask, how do we achieve that collaboration? And some of the other things you found when you looked under the hood, if you're willing to share that. So that's where I'd like us to direct our discussion when we return 2.1.
Absolutely.
Thank you. 15 minutes. Okay, members in the public, we're resuming. So welcome back, and thank you for the work that you've done, Mr. Lombardo, and the comprehensive and at points succinct presentation to us. Before the break, I mentioned focus on 2.1. Oops, I'm going to retract that and ask anyone to ask a question in any area they want. However, I do have a question, Mr. Lombardo, about 2.1 related to your recommendation of something that really sounds like vertical enforcement. And the 2.1, that is collaboration between the investigators, the expert witnesses, and the Office of the Attorney General. And you suggested that you stated, my interpretation, took a deep dive into some of the background of the problems we have that may have begun with cancellation of vertical enforcement. Can you just elaborate a little bit more about your observations that may have led you to believe that we should have an independent entity facilitating or fostering that collaboration that you believe is so important? And the reason why I initially talked about 2.1 is because none of us are satisfied with cases that take 3 years to solve. We understand that, and those of us on panels understand the problem we have with experts, and we understand why the Office of Attorney General does things that it does and makes recommendations that it does based on some of the experts' opinions. And so I just would like to have you talk a little bit more, whatever you feel comfortable about, your observations that led you to strongly recommend that collaboration that only makes sense, and we're aware of that? Hope that question makes sense.
Certainly. Let me start this way. Our observations, right, with the people, the operational people within MBC, all the sworn investigators over at HQIU, and the prosecutors over at the Attorney General's office, HQE, the 5 field offices, somewhere in the neighborhood of 55 prosecutors, right? They are all dedicated to what they do. There were cases, we saw cases that were referred over to the Attorney General's office, HQE, that had an extremely short window to fit within the statute of limitations, and those folks worked around the clock. I mean, they are really dedicated. All of these folks are dedicated. The Attorney General, I mean, they provided us with over, in the great VE termination debate, they wrote in excess of over a dozen memos strongly recommending that it does not end, because they realize the importance of collaboration. If I'm a prosecutor and I'm, okay, in the great debate covering 2017-2018, the Attorney General went on record multiple times, do not terminate VE, because without collaboration, it will greatly impede program outcomes. Okay? So they realize, in other words, the prosecutor, in bringing forth an administrative action, criminal actions are handled by district attorneys, but in bringing forth an administrative action, they have developed an expertise, right, over the years, right? And it's that prosecutor that has to go forth in filing that accusation, making sure that everything is there, evidentiary, medical evaluations, the burdens, the legal burdens of proof, they have to take all of that into consideration. It's considerable. And when they work in isolation, it makes it that much more difficult. Hence, look at the numbers, right? Over 1/3 of the cases that are put together, with sincerity, etc. In other words, we think we're building the case to the sufficiency it needs to submit it, but it's not there, right? That's why when you look back at the history of this program, I think it was 95 or 96 through about 2005, the Dagon District Office. The prosecutor, she or he, was put in the district office, and we comment on this in the first report, with investigators. So you got to know one another. There was this trust factor that was built, right? I'm the investigator. The prosecutor is here. We get to know one another's styles, what I need to do. The prosecutor is available when I have a question. I'm at a crossroads. I've got conflicting witnesses, or I got conflicting evidence. I've gathered these artifacts, and I need the legal review as to, is this sufficient, or do I need to take more steps? that worked, especially with the trust factor, because they got to know one another's styles. Well, all that evaporated, and when VE rolled in, and when you go and look at, I mean, all the great debate is out there, and we read it all. So one of the problems was, investigators have typically anywhere from 25 to 35 active cases, and depending upon the investigator vacancy rate in your office at that time, it could be even higher. And so on these cases, I'm working with one prosecutor. On these other cases, I'm working with another prosecutor. On these other cases, I could be working on yet another prosecutor. And so I may be getting different input and feedback. One prosecutor wants me to go in this fashion, another one wants me to go in that fashion. And so it, from the investigation side, it just created these problems. And ultimately, it led to the termination. But this model of getting desired outcomes, in other words, so a complaint has been filed, it's deemed to be actionable in the sense that we need to have a formal investigation, we need to have a medical expert evaluate it, and we need to have a prosecutor involved and review it, and either we're going to move forward with an action or there's no violation and we're going to close the case. Well, in order to effectively do that, you have to do that in real time together.
So my last question is related to the initial question, then we'll open up to the members. You have the memory or understanding of the entities. Why the facilitator? What's the value of the facilitator?
To get there. In other words, to build facilitators that specialize in bringing organizations together, whether you restructure or not, but agreeing upon what we're calling an MOU, a contractual agreement. There are individuals that specialize in this to get all parties on the same page and sign on the dotted line.
Thank you. Open up to the members. Ms. Lawson, Dr. Thorpe.
Yeah, so just to stay on this conversation about the relationship between whether it's medical board, DCA and DOI, HQIU, and then the Attorney General's office. I mean, in my understanding, and I guess I want to confirm it with you, is that the legislature controls how these things are structured, right? We know that there's a better way to do things. We need the legislature to authorize us. I mean, we've had the same issue and conversation on our fees, right? We know that we need a certain fee. They give us a different fee than we need, right? We know there's a better way to structure this, and the legislature, through its organization of government, right, in California, and then through its budgetary process, sets the parameters under which we operate. So, I mean, in many respects, our hands are tied unless they make the changes we would like them to make.
So I will say this, in reviewing state government over a period of years, different organizations within government, departments, agencies, enter into contractual relationships with one another, memorandums of understanding, and they do that, and they don't need statutory authority to do that, okay? You can construct that, right? If we were going to reorganize something, then there's a likelihood that the legislature would in fact come into play. But given the history of this program, I wouldn't, before I entered in, so everything stays the same, the Attorney General, DOI, HQIU, and NBC, I wouldn't, reduce it to writing without a legal analysis to make sure that you could do this absent taking this to the legislature.
Fair enough, thank you.
Okay.
No.
Well, let me say this. So what we have here, we have two constitutionals. So we have the governor, which all of state operations fall under, right? Including you folks, right? Consumer Affairs, the 36 boards. And then we have the Attorney General. They're a constitutional, right? As is the Controller, as is the Treasurer, as is the Secretary of State. So now we're talking about constitutional authorities, right? So, if we were talking about restructuring some of that, yes, there could well be the necessity to involve the legislature and also the constitutionals, right?
Well, frankly, it's more complex than that, right? Because, that's the governance, right? And that's how the state government itself is organized. But through the budgetary process, we're required to use the Attorney General's office as our lawyers, right? I guess you could eliminate that. I'm not sure that would be a good idea. I think they do a terrific job for us.
Right.
But through that process, we are required to use them, right? So we can't organize ourselves differently from a governance structure because of the way, the purse strings are controlled, frankly, right? So it's incredibly complicated, and I don't want to dismiss the fact that it is, but I do want us to think about it, and I was privy to some of those conversations about the MOU, and I appreciate the collaboration and the working group that's been put together and has been, trying to work more collaboratively to improve our processes. But many of our processes we're stuck with until the legislature, reorganizes us, chooses to do something different from a budgetary perspective, gives us the resources we know we already need to make some of these or enhance or make these processes more effective. So it's just, look, it's an editorial comment, really not a question, about the state of, again, a really complicated government in, the most populous state in the country. So I'll stop with my editorializing.
And yet every party, I interviewed, well in excess of 24 investigators. Kathleen Nichols said, Les, you can talk to anybody. She gave me the list, right? And even though VE was contentious, right, and there were a number of complaints from the investigator side, virtually every investigator told me, Les, during my work, I need access to prosecutorial feedback. I have to get direction from them. So there is, for all parties involved, the Attorney General's office, HQ8, everybody recognizes to get desired outcomes efficiently and effectively, we need to work collaboratively.
Dr. Thorpe, Dr. Yep, Ms. Rubiano.
Thank you, Mr. Chair. I would just briefly say, to me, and I guess this is not a question as much, to me it sounds like going back to the DAG in the district concept would be the best thing in terms of efficiency and productivity and all the things that we've been talking about. But it's very difficult to do that without legislative change. And this concept of a collaborative memorandum of understanding and using a facilitator to, because of the difficulty in getting agencies and personalities and all these things together to get on the same page, to actually create an operationally functional unit that would decrease the rate of return of of these cases from 35% closer. It's probably never going to be back to 5, but closer. It's certainly better than 35% anyway. I just think that's one of the most important things that we need to do as a board, because all of our frustrations, all the public's frustrations about the delay in our cases, the length of time it takes to get a complaint through the process, all of the complaints of our physician stakeholders that are held in limbo for a long period of time until they know what the outcome is going to be. All of this is affecting the actual functionality of this board and the really true operational functionality. Regardless of whether I'm here or somebody else is here, that structural function is the most important thing that we can do in the near term to try to improve this board's operational function. And that's my only, I just would make that comment.
Thank you. Dr. Yip?
Okay, yeah, thank you. A lot to learn. Two questions. One is about before the VE, after VE, was any cost analysis? Did we save money? Do we lose money? Without VE, so we can tell a legislator what would make sense to change. Looks like we're going to have big changes. And second is about the facilitator. I actually used to fly up to Sacramento home office, seeing some of the meeting with the DAG, the chief of enforcement, the investigator, very collegial and making going. Now, of course, we can do it on Zoom. So the question of facilitators is a one-time deal. He or she come in, take a look at it, draw the MOU, and that's it. You guys go to do it, or someone needs to be there at every meeting, every month. Can our chief enforcement be that facilitator? Because the DAG is we are the client of the DAG, we are the client of the HYU. They should do what we ask them to do. Do we have that authority?
So I'm going to start with the second question first. So depending upon the facilitator, and when I've done business process re-engineering, so the same kind of thing, so my methodology was, yes, to work with everyone through the process to get to the desired organizational structure. And then I would want to stay engaged periodically, monthly or quarterly, to evaluate how it's going, right? So there's the process of reaching agreement and putting all that in place. But how do we know that it works? And so when I've done this type of thing previously, I wanted to, the follow-up and the monitoring, so that if we did have to modify certain things to improve it, that we were, I was there, we were there so that we could do this to really get to how we were then going to operate from here on out. So, but again, depending upon the facilitator or the facilitating organization you use, they have different styles and methodologies. On the first question relative to the cost effectiveness, so VE started in 2006, and in 2010 there was a consultant retained, and they did the evaluation of the rollout, and in certain areas it was working and in certain areas it wasn't. And I'll refer you to that 2010 consultants report, but one of the statements I recall reading is, we're not getting the return on investment. So there was an analysis, a financial analysis relative to, are we achieving it? And then I believe in the great, what Les calls the great 2017-2018 debate, as whether to continue or not continue, yes, there was financial analysis done in that debate as to the cost and effectiveness.
What I'm saying now, 2024, with the new financial situation, cost of living, staff, etc., can we demonstrate it actually costs more without VE? Then we can tell the legislator we need to restructure the program because we can save more money. Number one. Number two, about the facilitator is that if someone who come one time to consulting and come every 3 months, to our budgets, another payment to another person.
Right.
I'm just wonder, if we hear all this problem, can Reggie even be the internal facilitator? Hey, I want all these things done, my staff all these things done, HQ you should deliver within some time frame, collaboration. Just when I'm looking at that facilitator role, is it something we need external really to twist everyone's arm, or is something just a concept that we can do ourselves?
I mean, you could, but we're just saying, because I read all the history, right? Everything that's been going on for over the last 20 years, right? And given all of that history, right? And the ups and downs and everything else, it may make sense to bring in somebody that's neutral, right?
I get it.
That
Thank you.
isn't attached to one organization or another, right? It may make sense to do that.
Thank you. I had a question about your recommendation regarding the 1-year retention
Right.
policy for cases with no issues. And I can see for some cases like the person was complaining about waiting too long in the doctor's office, something like that. I can see, closing those kinds of cases, but just wanted to hear more from you about that recommendation for lengthening time.
Absolutely. This was only in regard to cases that resulted in death and potentially very serious injury, but only those cases. In other words, we now have a case involving a death, right? Complaint came in, it was evaluated and determined we don't need to go forward with any formal investigation. Those, we believe, because of the significance of the type of case it is, because I think there's, 8 categories of case, we believe those records should be maintained for more than 1 year.
Got it. Thank
Just
you.
those. Okay.
So we have Dr. Dhingra, followed by Dr. Mahmood.
So I'm new, so pardon my ignorance, but I think what you have made this all recommendation, one of these main component is to want to cut down the time and a timely resolution of the complaint. And I believe there is two components there. One is your structural component, which is office complaint and Attorney General office. But I think you mentioned very important point, the execution of that complaint in terms of the medical investigators and the investigators in general. So even you solve the structural issue, which is you're trying to suggest in one of your slides that you can have the prosecution and investigator in MBC office versus in different locations. That could be one thing. And do you have an estimate or a kind of recommendation? If you solve the structural problem, what will be your timeline? Will be shortened, or it will be still the same? Because if you don't execute from the operational side, I don't think you will solve the problem. Just a thought.
Right. So when you go through our report on this section, and there's a couple of pages of what we documented from what I refer to as the prosecutor's summary memo, right? Detailing either they will go forward with an accusation or they will not, right? And this is the confidential memo sent to NBC, right? They outline either the evidentiary problems or the medical expert evaluation problems, and they identify it in detail, which requires a return, more substantive work. It goes back, it's returned a second time. If the prosecutor, for example, choosing the right medical expert the first time with the right discipline involved in this case, or it could be that we may need two different medical experts with two different disciplines. In other words, the prosecutor that knows what they have to achieve, if this is actionable, the threshold they have to meet, you're going to know that right then and there. And so you won't have to do more work. As a lay person, a non-prosecutor, when I was, and there's a detailed list in the report of all the, what we call the deficiencies. It was my estimation that the overwhelming majority of these would have been resolved if the prosecutor was engaged during the case. I think I shared with you in the last presentation, there was a time in my life, many years ago, as an auditor, and I was a certified fraud examiner, but there was a time that I did audits that were referred for either civil or criminal prosecution. There were times we were highly successful in achieving the desired outcome. These fraud cases, clearly fraud. And when we did that, we worked with the prosecutor. In one case, the Los Angeles County District Attorney's Office. We worked with that prosecutor from the get-go. So we built everything to meet her needs in proving the charges that she was going to file. When we did that, there were a couple of cases where we worked independently, and it was the handoff model, and there were problems associated with it. So by working together with the different disciplines that are required, you address those problems, the circumstances, so they don't become problems, requiring mitigation after the fact.
Thank you. Dr. Mahmood?
Thank you so much. I think most of the points you brought up, most of the members have been frustrated, and most of them have been discussed here in the meeting or outside the meeting, except one thing you brought in was bring another facilitation or facilitator department. We are already struggling with so many things. I completely share my sentiments with Christina, what she said about it's so easy to talk and it's almost impossible to get it done. This fight is going on for 20 years. It's not like it started yesterday or day before yesterday. Every single step we do, we need a lot more resources. And we ask for $100 and we get $10. All this talk can happen. Nothing can get to be implemented if we don't have the resources. So when we are talking about basic things, getting expert reviewers who can be paid not to the level of the private people bring it, even to half of that, it's been impossible. That is why we cannot keep them. We cannot have the investigators retained because they're not getting paid on the level other agencies are getting paid. So those basic things we cannot resolve when we're bringing more and more items into that. I think we're living in a dream. I personally think that we're going to be still fighting here 5 years from now, 10 years from now, if we don't practically go and address issue by issue, step by step, taking care of those things, then move on. And public will be equally frustrated, even more frustrated, because there is not a whole lot of trust right now, and it keeps on going. That will go down. And we will be blamed because we are not doing, actually, it's not really in our power at all. None of the people sitting over here on the board can do any darn thing if they're not given the resources. And staff cannot do anything if they're tied up with not able to do anything. So it's probably not a question, it's just my comments.
Dr. Butt, please.
Thank you very much. This has really been helpful to contextualize it in an excellent report, and thank you for your summary of what you distilled for us. Couple of questions, basic ones. This is now calculus. What goes in, what comes out, what's the rate? So when we looked at when you looked at we get reports that from HQIU that, gee, we got a declination. Things are moving faster. Seems like it. But what I heard, and it makes sense to me, that if what you're doing, and you don't count this, right? It's very hard to count back and forth, back and forth, back and forth, isn't it? Because that's not part of the calculation. It's a one in, one out. Doesn't tell us what's really happening, right? So somewhere in the report, I suspect you have a paragraph or a sentence or two regarding that and the potential time, and time is money, that costs. And I think to Dr. Yip's point, every step of the way, and Dr. Mahmood's, every step of the way has a cost. And I think every board member here shares the same as our healthcare advocates, as our patients that we're taking care of, our families that we're taking care of. Whatever, and I want to be optimistic about this. I think that the creativity of what we need to do has yet to be explored. But if we don't take it piece by piece, that's going to be a problem. So for example, just throwing this crazy idea, I have about 100 docs that I'm working around, right? And we're constantly going down to the court to be on a jury trial. Now, are there ways that we can not be in a jury trial, but there are probably some creative ways with CME, with protected time, and it's not going to be about paying me what I could get paid, $1,500 an hour, to sit on the other side. Mm-hmm. But I was an expert reviewer, and I did it because I felt compelled to do that. And I think that this two-tier thing, 150 versus 200 makes, I don't think I was on the board when that happened. I'm sure there's some rationale behind it. But that has to be addressed as well. It's never going to be the money. It's got to be something else. What do doctors want something else of? How can I get 15 CME really fast? Okay, that's really important to doctors because it's real hard, because it all takes time. But more importantly, I think that we aren't able to get people to do this work. It's hard work. Mm-hmm. The first report I wrote, it was like a big red pen. It says, "And you're at UCLA?" I mean, I was kind of embarrassed, but because I didn't know how to translate the legalese. I didn't know a simple departure. I read the sentence 15 times, and they still write articles about it, not us here, but it's difficult. So, I think that I feel optimistic, and I know that our last sunset review was a challenge, but under great leadership we did it, and I just hope for my colleagues on the board, let's think of some creative ways, and to Dr. Mahmood's point, let's take it step by step.
Well, thank you for that. We don't have the head of enforcement here today, but before we go to the public, I just want to, Mr. Rajesh, do you want to make any comments about anything you've heard or want to state?
Thank you, President Hawkins. So first of all, thank you for Les and your firm to conduct this audit and submit this report and come and present before the board. You started a discussion that is very timely, or maybe it's overdue. Your recommendations have not gone wayside. The staff have already started working on documenting all the recommendations, and what we are targeted to do is attack those low-hanging fruits that we can achieve right now. So going back to Dr. Ballad's step-by-step approach. So I would like to kind of share with the board and everyone what we have been doing since the report came out. So the first one is 1.1.1. For cases that are resulted in death and serious injury, to retain the documents more than a year. As I reported yesterday, that we already started imaging in the enforcement unit, so that should pave its way for, because we also have to be mindful of our the space that we occupy, all those file spaces that you see. So this is something that is a work in progress and under review. Also conducting interview with patient reps or individuals who filed a complaint involving patient deaths. So we have a budget change proposal for complaint liaison unit. That same BCP will have the complaint interview personnel or the resources that we are requesting, and that is already complete, and it is going through the approval process as we speak. So enforcement management, and no, that that budget change proposal will have to go through many layers before we know that it's been approved to the tune that we asked for, but that doesn't mean we are sitting just idle until it come back and approved. So the enforcement unit is already working on duty statements for those new positions identified in the BCP, and that once those positions are the duty statements are drafted, that also need to go through some additional review with DCA and them. And our goal is to start the recruitment process to fill those positions as soon as the budget approval comes in, not start creating the duty statements after the budget process. So that work is already going through. And we heard a lot of debates, and not going to spend our time on online complaint tracking system. That is also already complete from the standpoint of concept building and approved by the board. Now it is going through the approval stage, so that's already done. Now, establishing and restructuring a collaborative model, I'm going to skip that because we already spent too much time on that. That is a big elephant in the room that we'll have to work on that seriously. But that's also, I marked that as ongoing and under review. So moving on to section 2, the recruitment method for medical expert. Part of it is already complete, and it's also ongoing. Again, this is not something that we start with and complete and we say, well, done. No, this is an ongoing process. So recruitment, we continue to explore ways to recruit, and by means of advertising and outreach. That's something that we always talk about among the board members and the staff. And also moving on to the expert training. It is ongoing, and as we reported yesterday, we already very nearing completion of procuring the online training tool. Once that is once that's online, the two-tier payment method will go away, because we are going to require everyone to go through the training, all experts to go through the training. And now, because they can take it at their time, when they can, at their pace, and complete it, and then finalize the report. And once the report's accepted, they're all trained, and then there won't be any two-tier expert panel going forward. Also, establishing a formal process for soliciting medical expert training feedback periodically. This has already been in place before, where even in person, there was a survey at the end, right? So that's already completed. But with this online tool, we will be able to implement a post-test and a pre-test and a post-test before the training, also to find those areas where you say, well, was that training effective? Did the student or the medical expert learn anything going through that training? But at the same time, we can get their feedback online too, so that way. Now, much talked about the gap between current market rate of experts and our current experts, $150 and $200. Also, I'm happy to report that we actually submitted a budget change proposal last fiscal year that was denied because our fee structure, our funding structure, our funding imbalance, and our fee was not bringing in enough revenue to support those increased hourly rate that we were seeking. So it was denied contingent upon receiving a fee increase, which we do have now. So we are moving forward that budget change proposal to bring those market, the hourly rate to the market level, close to what the market is paying right now, or at least meeting what the market is. So very excited about that. We are hoping that that budget change proposal will be approved by the administration. Well, that's what we are working on right now, Dr. Hawkins. Thank you.
Thank you very much, Mrs. Varghese. And Mr. Lombardo, we appreciate your efforts, and thank you for coming to speak to us about your hard work to answer the questions that we need answered. If you have any final comments before we move to those in the room, you can make any, but don't feel compelled to.
I will just say this, that we have We have thoroughly enjoyed this engagement, the 13 months that we were on this, and we learned a great deal about the Medical Board of California. We sincerely thank you.
Thank you. Are there comments from the public present in the hearing room? If so, please come forward.
Sorry, could you activate the microphone there?
Turn it on. Okay, that makes a difference. Okay. Chaplain Reverend Queenie Ruth Summers, Tweedle speaking. Firstly, I would have to say that subsidizing by licensing is like one hand washing the other hand. You have people who are on one end putting out some money in order for them to be restricted if they have problems. And one of the things that we ran into with my husband's situation was that the doctor was not licensed we could find anywhere in the country, but within a matter of weeks, once we filed a complaint, all of a sudden he got a license. Okay, now, as far as keeping a workforce, pay and keeping a workforce are pretty much so tantamount, basically equal. And if you look at what's going on in our country, what's happening with these HMOs and so on, but then they're getting a ton of money and the doctors at the bottom are getting very little. So under those circumstances, they do all kinds of things to make money, and sometimes it's not good for the patients, but including harvesting organs or over medicating and things like that. So if you look at our country, in the United States, our CEOs make about 400% more than the people at the bottom. If you go to Japan, they make about 19% more, and across Europe, it's 24 to 25%. So there's a greed structure in there somewhere that's making a problem within, including our medical system. And then as far as not being able to find things, you can go back and find stuff on microfiche that happened back 100 years ago almost, as far as when you go into the property records. But and CDs are still keeping things, but we're getting to the point where you'll have a situation like what's going on with that company, MySpace, where people's music all of a sudden disappeared that they recorded because it was only electronic on a wire system. Now, we are basically victims of an offset of letters that said something wrong, and but it wasn't wrong enough, but we're not being allowed to find out. We're being refused to know what was wrong, and that seems to be a problem within the system. And then also this company needs, or should I say organization needs to be able to do DNA testing, where if you have some extremities, like the autopsy showed up, and that's another thing, why we know the doctor didn't exist is because the second autopsy company could not find the doctor that did, in order to say, hey, there's a problem with the autopsies. But we could not find him. But all of a sudden, he shows up in the records. Okay, and so we are being refused information, but along with it, like my mother-in-law, Dr. Tweedle, she cries daily about what happened to her son. And what we're trying to do is see if we can get this situation around to the point where it won't be like, for instance, when what the VA did to me. You can't have the stipend because we need proof that he's dead. But wait a minute, he died in a VA hospital. He had a VA autopsy, and along with that, but then you cut off the first check after he died, but you're saying you don't know he's dead. So we're in a situation where people are doing all kinds of strange things to us, but we can't find out what's
Reverend,
going on.
Time's up.
Thank you very kindly for taking the time with me, and you all be blessed and prospering always.
President, member of the board, there is another elephant in the room that the consultant alluded to, and that was the fact that he was an auditor before he came into this business, and he said, had he given you a financial statement, he would have said, you don't have the financial resources to contain or to fund your operation. And I would recommend that you seriously consider hiring somebody to look at your operation, how much you get from the licenses of doctors, and then break out where that money goes and how much of that money goes towards enforcement and court costs. Because as you mentioned yesterday, one of the things you were so primarily concerned about when bringing in doctors from other countries like Mexico was what happens if there's an incident where it has to go to trial. And those costs you were very much concerned about. Who is going to pay for that? You're faced with that same dilemma today. But nobody seems to be able to put their hand on it. I think if you had a financial audit done, you could break out where that is and how much more maybe you need in supplemental income to cover those costs that the legislature is unaware of. Because when you get your license fees, they only cover so much. And when the legislator put in what they thought was required, the CMA opposed it and they lowered it. And you're still, as your discussion was yesterday, you are still underfunded. You may have to borrow more money. And the other thing, as I mentioned yesterday, is you're using the Attorney General's office to represent your executive director in criminal court, to plead with a judge to suspend the license of a doctor because you can't do it. And legally, you can't. And he shouldn't have to go to court. The district attorney is bringing the criminal charges against the doctor, not the AG and not the medical board. The only thing you could do is suspend his license, and you can't do that when there's a criminal trial pending and the evidence that you would require to do that is involved in a criminal case. So I would urge you, I mentioned yesterday the need to do that letter. Get yourselves out from under that and eliminate those costs and give yourself the expeditious ability to effectively, once a doctor is charged with felony sexual assault of any member of the public, his license should be immediately suspended, and he's now under the jurisdiction of the criminal courts. And he'll get his day in court. He'll have his time to, the DA will present all the evidence. He'll have the opportunities to do all those things that he would have done before your administrative judge. I only urge you, if you can send that letter and you decide to do that next month or in May with your next meeting, I promise that with that, the legislature will be put on notice that they can't do it this year, they can do it next year. And that'll be a high priority. I then can use that to work with my legislator to show that this is something maybe she should carry the bill to give you that authority to do. Because she's talking about protecting the public. Your highest priority is the protection of the public, and you have to be able to do that. The legislature has to give you the power. They can't tell you this is your responsibility and not give you the ability to do it. So I urge you to seriously consider that letter, and I will do all in my power. As you mentioned the other day, when you oppose a bill, it carries weight. If you each of you sign that letter, it will carry weight. Please consider doing that and helping yourselves and helping us to protect the public. Thank you.
Other members in the room?
Good afternoon, board members. My name is Marcus Friedman. I'm the Administrative Director for the Consumer Protection Policy Center, formerly known as the Center for Public Interest Law. I know that 2.1 was discussed very in detail, but I do want to bring up the importance of a timely investigation for these types of adjudication proceedings. There are certain things, as Ms. Lawson mentioned, that has to go through the legislature in order to change. However, the investigation process, there are certain aspects of the investigation process that the board can impact themselves outside of the legislature. And cutting down the steps and how often the case gets passed hand to hand before it ends up into the hands of a prosecutor is crucial. I used to be a prosecutor, not at the AG's level, but when you're reviewing a case and you have to bring the case back for investigation because you can't make a decision, that's not a bump in the road. That's a roadblock. That pauses everything. And timing is crucial because the more time it takes to investigate before it's presented in front of an administrative law judge, the judge might consider how long it's taken for depending on the type of action. So if every action is taking multiple years to investigate before it actually can go forward, the judge might take that into consideration as well, which leads to lower results than we're expecting. So while there is certain things that have to go through the legislature to change the process, the investigation process is a smaller part in the whole entire adjudication proceeding that the board can look into and try and speed up because time is crucial. Thank you.
Thank you. Other members of the public?
Good afternoon. I'm Michelle Montserrat Ramos, and I'm with Consumer Watchdog. And I know, Reggie, you just mentioned some of the work that you're doing now, so it might be a little repetitive. One of the issues that we agree with Enforcement Monitor and recommend change is the retention of consumer complaints. I was actually a little surprised to read that in the Enforcement Monitor report because it's always been our understanding through prior board meetings and meetings with executive staff that the board retains consumer complaints for 3 years. And in doing so, it gives the board the opportunity that if a complaint didn't move forward because of a simple departure from the standard of care or whatever may be the case, and another complaint comes in, then the board can go back. And if that complaint moves forward to an accusation, the board can come back to that complaint, and it gives the family an opportunity to bring their complaint forward within the new accusation. So we were a little surprised to see that the board staff is purging complaints at the 1 year mark. And we agree that whatever policy we were told through executive staff meetings and board meetings should be the case. So we recommend that complaints are retained for at least 3 years, if not 5 years, for as long as the process takes for a lot of these complaints to go through. Another recommendation that we want to discuss was the deviation from the disciplinary guidelines. We agree with Enforcement Monitor that if these deviations are supported, then the complainant family has the right to know what the justification is to deviate from the guidelines. We want to know why the choice was made over rehabilitating the physician is more important in our case than protecting our family member. So we support the Enforcement Monitor's recommendation to give the public some type of explanation. And I know there has been some at times in accusations, but the public isn't really reading the 30 to 40 page legalese accusations, and may not see that. So if it's some type of explanation in the letter, the final closure letter, what have you. And lastly, the addition of Enforcement Subcommittee. As we've talked about before, we've asked for the Enforcement Committee to be brought back, and the Enforcement Committee could oversee these changes and also could go back to going into more detail about enforcement, with the public. Thank you.
Thank you. Are there others in the room?
Hello, my name is Lucas Evanson. I'm speaking on behalf of the California Medical Association. First, I would like to thank the Enforcement Monitor for his thorough work and analysis on the medical board's enforcement process. I would also like to thank President Hawkins and for reporting at the last meeting in his president's report about his interest in reestablishing an enforcement committee. The Enforcement Monitor recommended that an enforcement committee be appointed to oversee the implementation of Recommendation 2.1.1. The report contains many significant, complex recommendations that require adequate consideration and oversight to implement, so CMA believes that any report recommendation would benefit from a committee review process before consideration by the full board. This would allow a more thorough consideration than afforded at the quarterly board meetings, and the board would also be able to take advantage of the flexibilities allowed in SB 544 to allow for more remote meetings to accommodate the schedule of board members to ensure participation and quorum can be met. So CMA asks that any report recommendations be considered and be sent through an enforcement committee process. Thank you.
Thank you very much. Other members of the public in the room? Before we go to Web, do you have any information about the 1 year versus 3 year retention of records?
Yes, and I should have made sure that this was emphasized in the enforcement monitor report, just to make sure that there wasn't this misunderstanding. But the 1 year retention policy is only for complaints where it's been reviewed by a medical consultant and no violation was found. If there was insufficient evidence found to proceed, those complaints are maintained for 5 years. So I just want to make sure that that was clear for Ms. Montserrat Ramos and the members and the rest of the public.
Thanks for that clarification. WebEx?
The hand-raising features and Q&A window are open for anyone wishing to make a public comment. Also, if you're in a call-in only line, you can press *3 to toggle raising your hand. First up here, we have Rosie Arthur's daughter. Rosie, you should be receiving that prompt. Okay, we're going to move on here to Kim Turbin. Kim, you should be receiving that prompt on your end. I know you guys have had your hands up for a long time. If you walk away from the computer or anything, we can't open it up. So, Kim, it looks like your line's open.
Hi, can you hear me?
We can. Please go ahead.
Okay, hi, my name is Kimberly Turbin, and I am from Los Angeles. I'm a volunteer with Consumer Watchdog, and I'm speaking in support of my fellow advocates and all Californians in support of some of the enforcement monitor's recommendations. We agree with the enforcement monitor that the board should be keeping consumer complaints for longer than a year. We were led to believe that the board staff was keeping consumer complaints for at least 3 years. The only way that we can give other families an opportunity to some accountability is to ensure the board retains complaints for at least 3 years, if not longer. If board staff is purging consumer complaints within a year, then that is a problem that we can easily fix. We support the enforcement monitor's recommendations and further recommend that the board keep consumer complaints for at least 3 years, if not 5. We also support the enforcement monitor's recommendation to appoint an enforcement subcommittee, but we also understand that an enforcement committee already exists. Please bring back the enforcement committee, which can meet during the quarterly board meetings. The committee can oversee the enforcement monitor recommendations, as well as cover enforcement issues in great detail. Thank you.
Thank you for your public comment. Going here next to Marianne Hollingsworth. Marianne, you should be receiving that prompt.
Can you hear me?
We can, Marianne. Please go ahead.
Hello, thank you. Hello, this is Marianne Hollingsworth, Patient Safety Advocate. First, I want to thank Mr. Lombardo for his work on this comprehensive enforcement report. It's alarming to me as a consumer and patient safety advocate that the medical board's process for investigations is frankly so chaotic, shoddy, and poorly trained. It's no wonder that the median time for a case to go through the entire investigative and disciplinary process is now 3.85 years. This is the board's own figure, not mine. Now, the way I understand this enforcement monitor's report is merely a suggestion. The board is not required to follow any of the suggestions. Is this correct? And if there's no penalty, and then there's no penalty if you choose to do nothing. Investigators are not being heard and the AG is not being informed, so potentially dangerous doctors are allowed to stay in practice, often unfettered. How is this following the board's mission to protect patients? By having an inept investigative process, it ensures bad doctors remain in practice. In fact, you are putting consumers in danger with your current investigative process. I strongly encourage this board to actually follow Mr. Lombardo's suggestions in this enforcement monitor report. Incorporate the changes he suggests to save lives. Just don't wring your hands and claim you can't do anything to change it. If it takes legislation to change this chaotic and ineffective process, then make it happen. I guarantee you that legislators will listen to someone on the medical board because I know firsthand they won't listen to constituents who ask for changes. So it's up to you. You have to make it happen. Just don't ignore this important enforcement audit and say you can't do anything. Don't be satisfied with a job that's not even good enough when people's lives are at risk. Thank you for your time, and most importantly, thank you to Mr. Lombardo for his time and expertise.
Thank you for your public comment. Next up here we have Alka Ari. We should be receiving that prompt here.
Can you hear me?
We can. Please go ahead.
Great, thank you. I'm Olga Airy. I'm from San Francisco and I volunteer with Consumer Watchdog. I filed a complaint with the medical board in 2019 regarding my older sister's preventable death, and it was dismissed without an investigation. So many issues raised in the enforcement monitor's final report resonated with me. I was surprised to find out there were nearly 2,400 complaints closed without an investigation between 2016 and 2022 that involved patient deaths. Each death deserved an investigation, and I know each complainant was misled to believe an investigation would occur because I was one of them. This is a statistic no one should be proud of, and it needs to change. I was also surprised to find out one negligent act doesn't constitute a violation of the Medical Practice Act, and that it must be 2 negligent acts for the medical board to proceed further with an investigation. How is this okay? In my sister's case, an anesthesiologist made only one mistake. He deviated from the standard of care and failed to intubate my sister when the circumstances required it. It was one negligent act that created a cascade of catastrophic events that destroyed her lungs and eventually killed her. And yet that apparently didn't violate the Medical Practice Act. What it does violate is common sense. The standard needs to change too. I agree the board needs to retain complaint documentation beyond 1 year. The report says its sample size was reduced from 39 to 19 cases because documents were unavailable, and that shouldn't have happened. This needs clarification. I agree the board needs to be more transparent with justified deviations, i.e. when and why they are suggested. These deviations should be shared with the families who initiate complaints, recognizing their role as stakeholders in the process too. I also agree that when the justified deviations occur with most cases, then it undermines the credibility of these guidelines and confirms the public's view that the process isn't just or fair. There is a delicate balance between physician rehabilitation and patient protection, and this deserves more clarification too. I wish the report had addressed the issue of documentation better. The discussion around documentation focuses on patient medical records and yet says nothing about other records like patient notes, physician notes, emails, and other correspondence. If board investigations are limited to just the medical records, then the board isn't conducting a thorough investigation. This report confirms many of the problems with the process that the public has been bringing to your attention over the years. It doesn't address all problems, though, and I hope the board will continue to listen to our concerns. Thank you.
Thank you very much for your public comment. Next here we have Maria Bar-Navarrete. You should be receiving that prompt on your end.
Afternoon. I am Maria Ibarra-Navarrete. I am from San Jose. I'm a volunteer with Consumers Watchdog. I filed a death complaint on behalf of my brother that was closed at the Central Complaint Unit. My brother's toxicology reports from his autopsy came in late, and after I filed my complaint. By the time I had the information, my complaint was closed. A concern that was identified in the Enforcement Monitor's report was when the board deviates from the disciplinary guidelines. The auditor claimed that justified departures guidelines were common practice. and that the departures were supported. We agree with the enforcement monitor that some form of this information should be shared with the family. This is one of the main reasons why you have members of the public so frustrated with the process. If you share some of this information with us to show us how and why the rehabilitation of the physician was more of a priority than protecting our family and other Californians, we would gain a better understanding of how to proceed besides just complaining to you. Thank you.
Thank you for your public comment. Going back here to Rosie Arthur's daughter. Rosie, you should be using that prompt. Okay, I'm not seeing Rosie unmuting, so assume she's away from her computer or her hand. This time, Dr. Hawkins, I don't see any additional requests.
Okay, thank you very much. Moving to agenda item number 12, recommendations from the Specialty Faculty Permit Review Committee. Dr. Hauser.
Thank you, Dr. Hawkins. At our meeting on December 6th, the Special Faculty Permit Review Committee considered the qualifications of two applicants. The first is Dr. Antonio Omuro, who's applying for a special faculty permit in the Department of Neurology at the Stanford School of Medicine. In addition, Stanford is asking the board to approve Dr. Omuro's appointment as chair of the Department of Neurology. Dr. Omuro is an internationally recognized clinician with expertise in neuro-oncology, the treatment of brain tumors, and neurologic complications of cancer. He's currently professor of medicine at Yale University, and he is the chief of neuro-oncology at the Yale Cancer Center. If approved by the board, he will be appointed as professor of neurology at Stanford and will be appointed as chair of the Department of Neurology as well. The committee has reviewed Dr. Omuro's qualifications and recommends approval by the board for his special faculty permit and his appointment as department chair. The second applicant is Dr. Yoginder Singh, who is applying for a special faculty permit in the Department of Pediatrics at UC Davis. Dr. Singh is a clinician with expertise in neonatology, specifically echocardiography, point-of-care ultrasound, and neonatal cardiology. He is currently a professor in the Department of Pediatrics at Loma Linda University and is practicing under a special faculty permit was approved by the board in the past. If his application is approved, he will be appointed professor of pediatrics at UC Davis. The committee has reviewed his application and qualifications and recommends that the board approve his special faculty permit. Are there any questions from the board?
Mr. Chair, I don't have a question. I just move that we accept the recommendations of the Special Faculty Permit Committee.
So it's been moved and seconded. Any comments from the public present in the hearing room regarding this item?
Been on city councils and things of that nature, and I've never seen anything where somebody comes in and makes like a little blanket statement like that about we want this person to be in, and it's recommended by the important people, and so you guys should do it. And nobody even questions anything about the person's background or anything. That's just how it goes. I think that's a little bit odd. And I've done quite a, at my 71 years, I've worked in quite a few different operations, and I've never seen anything go that fast when you're talking about bringing in another employee. I mean, it's just, does anybody have any questions, you ask? And then somebody just goes on and says, I move that it happens. Didn't even give anybody else a chance if they did have a question. It's kind of different to me.
Any additional comments from the room? WebEx?
Hand-raising feature in the Q&A window are open for anyone wishing to make a public comment. If you're on a call-and-only line, you can press *3 to toggle raising your hand as well. Give everyone a few seconds here to see if anyone queues up. So any additional requests at this time, Dr. Hawkins?
Okay. Mr. Rothers, please call the roll.
Dr. Balat,
Yes.
Dr. Dingra, Dr. Helzer,
Yes.
Ms. Jung, Ms. Lawson,
Yes.
Ms. Lubiano,
Yes.
Dr. Mahmood,
Yes.
Dr. Thorpe,
Yes.
Dr. Sai,
Yes.
Mr. Watkins, Dr. Yip,
Yes.
Dr. Hawkins.
Yes. Motion carries. Moving on to agenda item 13, discussion and possible action related to the rulemaking on citation and fines. Ms. Webb.
Thank you, Dr. Hawkins. Members, will you please turn to your materials under agenda item 13? And this proposed rulemaking amends the citation and fine regulations under Title 16 of the California Code of Regulations, sections 1364.10 and 1364.11. The purpose of this rulemaking is to update the board's citation and fine authority. A long time ago, before any of us were involved, the board decided to make a list of statutes and regulations for which it could issue a citation for a violation. This meant that anytime a statute or regulation relevant to the board's jurisdiction is added or repealed, the list of citable offenses is out of date in this regulation. Several other DCA boards chose not to develop a list of citable offenses and so have broader authority to issue citations, including Board of Pharmacy, the Dental Board, the Board of Registered Nursing, and the Board of Chiropractic Examiners. The proposed changes streamline the list of citable offenses and add language to include that violations of relevant practice acts, so that would apply to physicians and surgeons and licensed midwives, the board's regulations, and any other statute or regulation upon which the board may base a disciplinary action, all of those would be included in these regulations as citable offenses. The proposed rulemaking also raises the cap for fines up to the full extent authorized by law. This rulemaking went through the 45-day comment period, and the board received comments from the California Medical Association. A summary of CMA's comments and the proposed responses to reject them are included in the staff memo. Additionally, the noticed text and CMA's actual letter are also included in the materials. I'm sure that you've had an opportunity to review them. CMA wants the board to maintain a list of specific citable offenses rather than to amend the regulations to indicate that a violation of the Relevant Practice Act or any other statute or regulation upon which the board may base a disciplinary action are citable offenses. Staff recommends that the board reject the comments and move forward with finalizing the rulemaking with the text as noticed. I'm happy to answer any questions or review CMA's comments in further detail if the members would like. Otherwise, I have a specifically worded motion that I would like to suggest. So I will turn it over to the members for any questions or comments.
Questions or comments from the members? Dr. Thorpe?
So just in regard to that concern about an overbroad ability for us to cite and fine, and I am not necessarily, I just want to understand it more completely. If we take this broader approach to cite and fine types of discipline, what are the risks that we will inadvertently overstep our authority, I guess is my question.
I may not understand the question. I know that CMA raised a concern that maybe the board would be pressured to choose to issue a cite and fine in an action where greater discipline was warranted. Licensees already try to get the board to issue cite and fines versus pursuing more I'm sorry, cite and fine is not considered discipline. It's an administrative enforcement action. If an accusation is filed or there's a pre-accusation public letter of reprimand, that's actual discipline. So licensees will try to get cite and fine rather than an actual disciplinary action. But the board uses discretion to determine when a disciplinary action is necessary to protect the public, or when a progressive form of discipline can be used in appropriate cases to get the physician's attention or the other licensee's attention, have them take the corrective action. A citation can include a fine, but it doesn't have to. And it can also include an order of abatement, meaning you are not turning over records. You need to turn over the records in a timely way. Here's your citation and fine and the order of abatement that you do this within 10 days, for example. Not everything requires a formal disciplinary act, and so a citation and fine can protect the public by getting the licensee's attention, having them correct their behavior, and certainly if another complaint comes in down the line, the fact that they got a citation is information that the board uses when determining what the appropriate level of discipline is for the next time. So I don't think the board needs to be concerned about overstepping. These are public, and also the licensees can challenge a citation and fine, first through an informal conference, and if they're unsatisfied with that, they can go to hearing, and in those cases come before the board members.
And just to clarify, when you say the board uses its discretion, that's the administrative staff makes that
Yes.
that decision about what
Yes.
can be done. Okay.
Are there other questions from the members prior to my request for a motion that requires specific language for these type of processes? Ms. Webb, could you assist us in making a motion that requires a very specific language?
Yes. So I'm going to suggest a motion. If any member agrees with it, they can say so moved, and then we'll see if there's a second. So the suggested motion would be to direct staff to proceed as recommended, to reject the comments as specified, and provide the responses to the comments as indicated in the meeting materials, and to direct staff to take all steps necessary to complete the rulemaking process, including the filing of the final rulemaking package with the Office of Administrative Law, authorize the executive director to make any non-substantive changes to the proposed regulations and the rulemaking documents, and adopt the proposed regulations as noticed for Title 16, California Code of Regulations, Sections 1364.10 and 1364.11.
So moved.
Second.
It's been moved and seconded. Any comments from the public present in the room?
Hello, everyone. My name is Lucas Evanson. I'm speaking on behalf of the California Medical Association. I'd like to thank board staff for taking the time to review and respond to our comments. CMA maintains that establishing a clear list of statutes and regulations eligible for a citation and fine provides physicians and consumers with more transparency about how the board will handle specific deviations from the law. For this reason, we ask that the board reconsider using a specific list of statutory and regulatory code sections eligible for citation and fine if violated. Thank you.
Thank you. Other comments from persons in the room?
Chaplain Reverend Queenie Ruth Summers, Tweedle. I am asking you as he mentioned, to have a list of what the actual problems are that you will be looking at in order to determine whether or not something has taken place. And then we need to, as the public, be able to see what did take place in reference to the investigation, because it gets to be nauseous to receive letter after letter. First, you're dealing with the Department of Justice. Next, you're dealing with the
Reverend,
initial
it
review
doesn't
board.
sound like you're commenting on the proposed regulation.
That's what I am. I'm commenting on, I'm saying we go through all these changes to get to you, but then once we get to you, well, then we get back letters that are generalized saying, well, it's nothing that can be done because not enough was wrong. And I'm saying if you're going to put together a list of what's wrong, we need to know if you say something was wrong, what on that list was wrong when you're sending us back a comment in reference to what we have sent to you. I'm not trying to be difficult with everybody. I'm just simply saying that if you say somebody did something wrong, but it wasn't enough, let us know what the wrong is. That should be a part of this particular situation, since you're coming up with a list of things that would be the regulatory points for the persons. We need to know what they're being regulated on. And please forgive me, it just gets, at times it gets nauseous dealing with it. Thank you. God bless everyone.
I want to know if any of that applies to dental as well. I need to go up to the microphone. They can hear me.
No, you have to come up to the microphone, please. Please identify yourself. Thank you.
Beverly Taylor from the public. I'm trying to find out how much any of what you're talking about applies to dental. What I'm dealing with are all these different issues, but I'm getting no results. Okay? And I'm trying to find out what actually applies to dental. Because I have a crucial dental issue that I've been dealing with for some years. As a matter of fact, I've gone through the gangrene, cancer, and all situations. The only thing left for me now is to pass on.
I'm happy to talk with you after the meeting and put you in touch with the dental board.
Okay. Thank you.
Comments on WebEx?
The hand raising feature and the hand raising feature and the Q&A window are open for anyone wishing to make a public comment. If you're on a call-in only line, you can press *3 and only in order to toggle raising your hand. We'll give everyone a few seconds to queue up. See if anyone's interested. Not seeing any requests at this time, Dr. Hawkins.
Thank you very much. We have a motion that's been seconded. Ms. Strothers, please call the roll.
Dr. Bolat,
Yes.
Dr. Dingra, Dr. Helzer,
Yes.
Miss Lawson,
Yes.
Miss Lubiano,
Yes.
Dr. Mahmood,
Yes.
Dr. Thorpe, Dr. Sy,
Yes.
Dr. Yip, Dr. Hawkins.
Yes. Moving on to agenda item 14, discussion and possible action related to the rulemaking on the physician and surgeon health and wellness program. Again, Ms. Webb.
Thank you, Dr. Hawkins. Please turn to agenda item 14 in your materials. This item relates to the proposed rulemaking to establish the Physician and Surgeon Health and Wellness Program, or PHWP. The board is authorized to establish a PHWP pursuant to Business and Professions Code Section 2340 with the goal of providing early identification of and appropriate interventions to support rehabilitation from substance abuse to ensure physicians remain able to practice medicine in a manner that will not endanger the public and will maintain the integrity of the medical profession. Business and Professions Code Section 2340.2E requires the PHWP to comply with the uniform standards regarding substance abusing healing arts licensees. The proposed text went through the 45-day public comment period. the board received a request for a hearing on the proposed text, and the hearing was held on November 14th, 2023. The notice text, the summary of the comments and the proposed responses, as well as the actual written comments and a transcript of the public hearing are included in the materials. The comments from the patient advocates, professional associations, and subject matter experts with experience in physician health programs were negative. It does not appear that this is the program interested parties had in mind. The problem is that the substantive issues raised cannot be resolved with changes to the proposed regulations. Many of the changes that the subject matter experts and professional associations request are not consistent with statutory authority or the uniform standards. Many of the comments express concern that the requirements for the program will deter physicians from seeking help and could be harmful to physicians who enroll. Because of the nature of the comments, the board may wish to consider whether it wants to move forward with a program under the current legislative framework. If the board does want to move forward with the PHWP as proposed, then I have a specific motion I would like to suggest. If this is not the program that you want, then you can direct staff to withdraw the rulemaking, or you can set it for further discussion on a future agenda to obtain additional information about best practices for physician health programs as compared to the requirements for this program. If the board decides to proceed with establishing the PHWP through this rulemaking, then again, I have a suggested motion. So I will turn it over to the members for discussion.
So with this, Cynthia, I think I'm going to deviate from the order and take comment first from those in the room, followed by WebEx, and then come back to the board. Are there persons in the room who would like to make a comment on this particular item?
Good afternoon, members of the board. Again, my name is Marcus Friedman, Administrative Director for the Consumer Protection Policy Center at the University of San Diego School of Law. CPPC is a nonprofit, nonpartisan academic and advocacy center at USD School of Law. We've examined and critiqued California's regulatory agencies for over 40 years. Our previous Administrative Director, Julie Felmuth, was appointed the Medical Board Enforcement Monitor in 2002 and directed an in-depth investigation and review of the Medical Board's previous diversion program. The program was audited 5 times in its 24-year existence and failed all 5 audits. The most common problems were understaffing, lack of resources, inability to detect relapses, and the board's failure to adequately oversee the program. After the 5th audit, the board voted to end the program in July of 2007 and was abolished on June 30th, 2008. Business and Professions Code Section 2001.1 states, "The protection of the public shall be the highest priority for the Medical Board of California in exercising its licensing, regulatory, disciplinary functions. Whenever the protection of the public is inconsistent with the other interests sought to be promoted, the protection of the public shall be paramount. We are concerned that an audit every 3 years is not the oversight needed to ensure the diversion program is successful. If the board members today are unable to actively supervise this new diversion program, then the diversion program should not be pushed forward at this time, as it conflicts with the protection of the public interest. Further, the Administrative Procedures Act references 6 criteria when determining a review of the proposed regulations, pursuant to Government Code Section 11349. The 6 criteria are necessity, authority, clarity, consistency, reference, and non-duplication. There were 9 written comments in response to this proposed regulation, and each addresses concerns that involve the 6 criteria in one way or another. Take one of CPP's comments, for example. We raised an issue over the vendor's authority to impose practice restrictions. Proposed Section 1357.11 states, if a vendor imposes practice restrictions on a participant, the vendor shall report in writing to the board within 1 business day, with certain information to be made public on the board's website. The major concern with this section is whether the vendor has authority to impose the practice restrictions. The staff's report's response stated the medical board has authority under Business and Professions Code section 2340.4A to contract with a private third-party entity to provide services for the board's established program. However, the code section does not address the issue of the vendor having the authority to impose practice restrictions. We cannot identify a code section that lets the medical board hand over authority to a third-party entity to impose practice restrictions. While this is just one example, we urge the board members to ensure there is consistency with the current law and the board is using appropriate authority granted to it by statute. CPPC urges each board member to consider whether this diversion program is truly a priority for the protection of the public interest. Nothing in the law requires the board to create a new program to monitor substance abusing physicians. In light of this board's history in the public protection, we respectfully urge this board to reconsider that decision. Thank you.
Thank you. Thank you. Other members in the room? Public members?
I have a couple. Chaplain Reverend Ruth Summers Tweedle. I have a couple of questions in reference to the notations here where it says that there was a 45-day comment period. And what I'm attempting to find out was, how was that put out in front of the public to find that? Because I was at the meeting in Sacramento, the only person that was there from the public. And and in the meantime, I'm trying to figure out, when was this brought out to the public that we were supposed to be have a period of reviewing this or giving any comments? What happened with that?
I'm happy to help walk you through being a subscriber to the board's alerts.
Yes.
And tell you the other ways that it's published.
Thank you very kindly.
I am Michelle Montserrat Ramos, and I'm with Consumer Watchdog. This issue is very important to me. It's the reason why I became a patient advocate and the reason why I became a medical board advocate for so long. I've dedicated about 13 years to this issue. You may wonder why. I became widowed due to a substance abusing doctor. My husband-to-be, Lloyd Montserrat, died following elective surgery, unknown to him and I that his doctor was addicted to crack cocaine and had a long arrest record, including felony possession of crack cocaine and prostitution. Lloyd and I didn't have the right to know that his doctor was an addict, and it caused Lloyd to lose his life at a young age, just months before our wedding. I couldn't understand how a doctor, that the state could allow a doctor like this to practice. So I put my grief to the side and I got busy. I was one of the 3 people who presented to the board in 2007 to terminate the old confidential physician diversion program. I was at the diversion hearing at the Capitol in 2008 and was given the opportunity to speak at the end of the hearing because I knew the chair of the committee and he knew and respected Lloyd's work. He gave me the opportunity to speak, and SB 1441 uniform standards were born right out of that hearing. I spent the next 5 years fighting the board to place uniform standards into regulations. Carrie knows this, she was here. I had to go to another legislator to get his help to make that happen. In between, I spent 8 legislative cycles fighting to keep the program terminated. I finally lost. I had to make peace with the fact that the program was coming back, but my one solace was that the uniform standards were in place and that the board and programs had to follow the uniform standards whether we had a program or not. Fast forward to today. I read the regulations. I understand it is mentioned at the top of the regulations that the uniform standards must be followed, but for some reason the regulations are written without citing the uniform standard that applies. If you read our letter, we're requesting that the regulations be revised to cite the uniform standards that applies and the consequences that a member faces if the uniform standards are not followed. We're asking you to revise the regulations so there are no misinterpretations by the program or later by this board when a member commits a minor or major violation. Right now, the regulations are so vague that they could easily be misinterpreted. This law was drafted to prevent this program from failing the same way that the old diversion program did. We're asking you to delay voting on this issue till the regulations are revised and you take the public's comments into consideration. You know, we've received email from healthcare professionals asking us for help because they can't understand how an impaired physician is allowed to practice with them in their hospital while they were on duty, and they couldn't find the physician, and they're asking us for help. So basically, we're asking you to not only help the physician in the program, the public, but also the healthcare professionals that are working with them as well. Thank you.
Thank you. Are there other members of the public in the room?
Hello, my name is Lucas Evanson. I'm speaking on behalf of the California Medical Association. Again, I'd like to thank board staff for taking the time to review and respond to all the comments the board received. As much as we think we need to review the underlying statutory construct of this program and update it, we also don't think inertia is acceptable. We need to keep moving forward. CMA asked the board to reconsider two requests CMA made in our letter. First, we would like to point out that when the bill authorizing this program passed and the decision to require the physician bear the full cost of the program was made, the board did not have the authority to issue cost recovery. CMA believes it is overly punitive to require physicians undergoing rehabilitation to also pay the cost of their investigation. Reimbursing them any cost recovery when successfully completing the program would also provide additional incentive for physicians to follow treatment, recover, and return to regular practice. Second, the decision not to include any warnings about the program scope being limited to substance abuse is concerning because the program's title is Physician Health and Wellness Program. As you may know, in the medical community, the word wellness is associated with mental health treatment and resources. CMA is concerned a physician with severe mental illness and worse, suicidal ideation may desperately call the program, and the program would be ill-equipped to handle the situation. Ultimately, though, we need to keep moving forward with standing up a program, so we ask that the board continue with the rulemaking process and adopt the staff's proposed language, but consider incorporating the language relating to these issues in CMA's letter to encourage more physicians to successfully complete the program and establish some precautions for physicians in dire mental health crises. Thank you.
Thank you. Other persons in the room with comments? WebEx?
The hand-raising feature in the Q&A window open for anyone wishing to make a public comment. Also, if you're in a call-only line, you can press *3 in order to toggle raising your hand. Give a few seconds for anyone to queue up. Might be interested. This time, Dr. Hopkins, I'm not seeing any requests.
No. Okay. Ms. Webb, I'd like you to restate the board's options regarding this entity prior to opening up for the members to...
Sorry, Dr. Hawkins, a late request came in.
Okay, please, proceed. WebEx.
Maria Barr-Navjaret, your request should be coming your way.
Thank you. I am Maria Ibarra-Navarrete. I am from San Jose, and I am a volunteer with Consumers Watchdog. I have to admit that I find it rather alarming that we are talking about bringing a program back for substance abusing physicians. I feel better knowing that there are uniform standards that provide consequences when members of the program fail a drug test or violate the program in some way. As I mentioned at the public hearing, my concern is that the uniform standards are not currently cited in each regulation where they pertain. The specific uniform standard needs to be cited and what the outcome is if the uniform standard is not allowed. SB 1441 is the law, and it needs to be followed. The only way we can assure that the program is safe for physicians and their patients is by specifically stating the uniform standards, so there is no misinterpretation anywhere in the process, including when an enrollee does not adhere to the guidelines and the case is brought forward to this board. please delay voting to approve these guidelines until the regulations are revised to specifically cite the uniform standards and to ensure that the public comments are taken into consideration. Thank you.
Thank you for your public comment. That was the only request in queue, Dr. Hawkins.
Okay, thank you. So, Ms. Webb, could you repeat our options relative to this item before opening up to the board?
Yes, may I explain a couple of things before I do that?
Please do.
Okay. The first thing is, you've heard the term diversion mentioned a couple times. This is not a diversion program. There's two ways to get in. One is that the board refers the person as part of their disciplinary order. And the second way is a self-referral that does not come through the board. The physician would self-refer, and the board will not know about them unless they have a practice restriction or they commit a major or minor violation, or they withdraw from the program or are terminated. This is not a situation where the person comes to the board and the board diverts them to this program in lieu of discipline. With regard to imposing practice restrictions, the physician will have to enter into an agreement with the vendor to agree to comply with practice restrictions. This is the only way it could work, because the vendor can require them to limit their practice to a certain number of hours, limit what they can do, go into inpatient treatment. And if there is a practice restriction, the uniform standards requires the vendor to notify the board, and the board posts that on the physician profile without indicating what the source of the practice restriction is.
Excuse me, could you further define the vendor?
Yeah, the vendor would be the entity that's chosen through the contract process to run the PHWP.
Thank you.
With regard to citing all of the uniform standards in the regulations, the uniform standards are not statutes and they are not regulations. They have no effect until they are placed into regulation. So what this proposed regulations do is cite to our existing regulations that implemented the uniform standards. The initial statement of reasons explains, it's a large document that has to explain why the language is the way it is, and it indicates what the uniform standard is that is being relied upon. But citing to the uniform standard, it has no effect. It's citing to the regulation that implemented the uniform standard that is necessary. So with those explanations, and I'm happy to answer any further questions on this, but the potential options are to go forward with the text as it's written, withdraw the regulation and not take any further action at this time, to table voting on the regulation and to set this for a future agenda item to obtain additional information about physician health and wellness programs that are already implemented in other states, to determine if this is the legislative structure that the board wants to develop a physician health and wellness program with. If it's not, then you have the option to not moving forward with this regulatory package.
Thank you very much. We open up to the members now.
I just have a specific legal question that then may affect my comments. If we do move forward with this program and the legislature makes changes eventually, I mean, what is the impact of that process? I mean, so I guess that's to say, I would hope that in the future, the legislature will make some changes that allow us to do some other things that across the country are widely being done and are widely considered best practices. At the current time, we are hamstrung by the statutory scheme, much like we talked about earlier, that exists today. And so if we do take action to advance this, because, I mean, frankly, this is a void that it exists in California right now, again, that doesn't exist in other states. If we take action to advance this, are we limiting our options if the legislature does make changes, or actually does it facilitate us already having a program that then could be adapted if the legislature makes some changes? I guess I just want to make sure if we do take action that we're not limiting our options in the future, potentially.
I mean, it's hard for me to answer that for sure. They might factor in that if the board takes action on this, that the board is satisfied that this is a program worth pursuing. So they just may factor that in. Or they may say, you're going down this path, but we're changing the statute, so you're going to have to change your regulations.
Yeah, so I guess to make a comment, I continue to believe that having no physician health program, physician health and wellness program, whatever you want to call it, is not acceptable for the state of California, and that's the position we're in today. I mean, I did, you know, Carrie, you made some mention about the diversion program and the fact that this is not a diversion program. I appreciate that. We get a lot of feedback on that point, or a lot of input. And I mean, frankly, I don't think any of us as board members were here when all of those various things were happening, but it is a best practice nationwide. It is a best practice internationally to have this type of program. I'm a licensed attorney in the state of California. We have a similar type of program. Actually, it's broader. And so, I mean, we need as many opportunities as possible to support physicians' mental health and wellness, support those that have substance abuse issues and want to solve them. So, I mean, my thought would be for us to continue to move forward with this as it's written and as it's gone through the rulemaking process, you know, getting us here today. That's been a lengthy process. I also want to continue to work with the legislature and with all stakeholder groups to think about how we can improve the program going forward.
Thank you for those comments, Ms. Lawson. Additional members? Dr. Thorpe?
Thank you, Mr. Chair. I also agree with Ms. Lawson about the importance of the physician health program in California, that it is, you know, here we are, typically we lead the country in all kinds of things, and we are one of, I think, 3 states that doesn't have a physician health program. So this clearly is needed. My biggest concern is that some of the objections to this rulemaking process, or to this regulation, the regulatory language that we have, is that it really is not what we know in terms of best practices. It really, truly, and I know that part of that is because of our legislative, you know, because we've been kind of hamstrung by the legislature. So I'm conflicted. On the one hand, I would like to have this program be, I guess I'm not sure if it's better to have a program that's not the best. You know, I mean, what we really want is we want doctors who are in these situations to actually volunteer to become part of a program so that they can get help, right? We don't want them practicing secretly. We don't want them hiding their issues. We want them to come forward, and it's hard enough to do that in any kind of situation, but especially if it's punitive, it becomes very, very difficult. So I'm struggling to decide whether I think we should table this to try to get more input and try to get better, maybe make this better. But I know this was something that I was very committed to doing when I first came on the board, and it's been over 3 years for this process to go through, and so I guess I'm not sure what I'm saying. I guess I'm a little conflicted, but I guess I would speak in favor of going forward.
I think I understand what you're saying, Dr. Mahmood and then Dr. Balat.
There's no doubt there's a lot need for this, and if already 47 states are ahead of us, I think it doesn't have to wait a little longer to be convinced, to be satisfied what we are bringing on, and everybody get chance to go through this thing and probably bringing this to a next future agenda, probably next meeting, and everybody should put more concentration and focus on this and come prepared and then go on with this thing so that we are doing the thing. Maybe we're doing it at the last, but at least we should be sure that we're doing the right thing. So that's what my comment would be.
Dr. Balat? And
Yes,
then Dr. Hauser.
Yes, I was going to say I support Dr. Mahmood's comment. That was the similar comment I was going to make. We should be leading, as I think Ms. Lawson said, and I do completely understand the issue of being hamstrung by legislation. So I would like a little bit more time to think it through and make sure that all the tick boxes are checked. So I would not be in favor of moving forward. Table it.
Dr. Hauser?
Ms. Webb, if we do not move forward today, do we have a timeline by which we have to approve these regulations or start over again?
Yes, so we've got a year from the date it was noticed. It was noticed in September 2023. And what that means is if it's not finalized and approved by the Office of Administrative Law, then we would start over with the 45-day comment period. But the hardest part, if this is ultimately the program that you want to go forward with, was getting the language organized and drafted and approved through all of the layers. So that was really the thing that took a lot of time. I would anticipate that if it went out for another 45-day comment period, we would get very similar comments that we've already seen, if it's the same program.
So if we were to delay this until our next meeting and have a presentation, we probably would have to start over again. Is that what I'm hearing?
Not necessarily. If at the May meeting you decided to go forward with the rulemaking at that time, then it's a matter of completing the final statement of reasons and having Department of Consumer Affairs and Business Consumer Services and Housing Agency approve that and get that submitted to Office of Administrative Law. So it would be a tight schedule, but not impossible.
Thank you.
Additional members? Dr. Thorpe?
I move to table this until the May meeting.
Can I ask a question about that motion or offer a comment? What do we want our staff to come back with at the May meeting? Because, I mean, what additional information do we need?
I think you'd want to have this subject expert presentation that actually, I don't know how easy it is to get that. We try to get artificial intelligence, and it's taken a while. There's a great person, but they're busy. So what's the likelihood of us getting someone to come before us to present best practices? We're told that almost every state has a program.
Well,
that's how I would see it.
Mr. Chair, I think one of the concerns is, Obviously we're one of 3 states that don't have it. What are the other 47 doing? How successful are their programs? I think if we have a compare and contrast, we can sort of pick out what's successful for other programs and then sort of adopt it into our own. One of the problems with sort of moving, it's a great idea. I think we definitely in support of it, but we just don't want to put a product out there that has a lot of flaws and then we have to recall it and then or fix it up, and one and done is better than going back and tinker it with it many times. That's how I feel.
Additional comments, inquiries about the motion?
I mean, I'm not going to support the motion. I think we should do something sooner rather than later. We're just languishing here. We're doing nothing. I mean, this has been on our board agenda multiple times over the 8.5 years that I've been on the board. I mean, by the way, the best practices, they don't look like this program, right? I mean, they look different. They don't look like this program, by the way, because of the problems with the past diversion program that, again, none of us have anything to do with, and none of us were overseeing at the time, and maybe things would have been different had we been there, but we weren't. But we're stuck in this process because, I mean, there's a lot of hangover for good reason, right? I'm not saying there's not good reason why that program was terminated and why that program should have been terminated, but we're suffering the hangover as a result in that we can't get a program that is based on best practices put into effect here, right? FSMB had a great, a great seminar, and Reggie and I talked after that meeting about, hey, let's bring this person here, but the statute isn't going to let us do that program, right? Which is the best practice across the country. So, I mean, I guess if we're tabling this today, we should tell the legislature loudly and clearly that we want to do something else, right? That the reason we tabled this and we're going to have another conversation about it is because we don't think this works. We don't think it's the best practice, and they should give us the authorization to do something more along those lines. So that's my final comment.
Thank you. Dr. Palat?
No, I was just going to support
Ms. Lubiano.
what Ms. Lawson said. We do have to have something, and I do think if it's in our it is. I think if the board agrees, I think that message does need to be set loud and clear to the legislators from this board.
Ms. Lubiano, I think.
Oh, yes, thank you. I'm also with Christina here. I would support a motion that has specific guidance on what else we'd like to look at specifically. And it makes me think of making progress and not wanting perfection. And just as a parallel to our complaint tracking system, it doesn't have all the bells and whistles, but we're going forward with, with something and adding stuff later. So I also want to make sure we do something. Thank you.
I'm told by our webmaster that there are individuals, the public, on the web, one person. I'll allow it.
Thank you, Dr. Hawkins. Marion Hollingsworth should be receiving a prompt on you.
Okay. Here we go. Can you hear me?
You can, Marion. Please go ahead.
Okay, thank you. This is Marion Hollingsworth, patient safety advocate. What I don't understand about this issue is why the board and the CMA keep saying that the doctors need help when they can get help anytime they want on their own without as much personal cost as this program would require. It's pathetic that this board is more concerned about physician wellness and not consumer wellness. You have no concern about putting a surgeon on probation for the killing of 3 patients. And yes, there was one in my area that recently killed 3 patients and got a discipline that was not even the minimum under your own disciplinary guidelines. Yet you scream about the poor doctors when they have drug addictions or alcohol addictions. Yes, it's a problem, but they are adults and can decide for themselves if they want to do something about it. And if they're forced into a program like the ones you have pushed, there's no guarantee it will work. Look at Hunter Biden. He's had a problem for years. Just because states have best practices doesn't mean this board has to do the right thing. Remember, our parents always told us that just because other people were doing something dangerous doesn't mean you have to do it too. I urge you to pay attention more to the regulation and enforcement programs that actually protect patients than to once again come to the rescue of doctors. Thank you.
Thank you for your public comment. Next
What's
here
it-
we have Eric Andrus. Eric, you should be receiving that prompt on your end.
It's shockingly disgusting that any of you sit on your high horses up there thinking that doctors need a health and wellness program when you can't do your one job properly to protect all of the people of California from the very people you want to make sure have access to these programs. What about all the non-doctors in our state, like our veterans in our state, who can't afford to go to such programs and end up in the street? What about our non-union teachers who can barely afford rent and have to deal with the stressors of babysitting our children and not having enough money for school supplies, who might have addiction problems and can't get help? My roommate, a veteran, who just tried to commit suicide 6 weeks ago, still can't get help from the Veterans Association while they just keep sending him more and more medication. Why do you think it's appropriate to take care of doctors and lawyers, both professions who often make very large salaries, when the dearth of people in this state don't share the same offering of such a program? Most doctors can afford to pay for their own recovery programs since they save so much in comparison with other licensing agencies over costs for licensing. It costs more to be an actor than it does a doctor as far as license fees, and actors don't have a health and wellness program either. I think most of you are just afraid to speak up and say anything negative about doctors, especially with Richard CMA Thorpe sitting there staring you all down. It's shameful. I'm thankful that even with all the medical errors that have killed my family, I don't have an addiction. But if I did, I couldn't afford a recovery program. Are you all concerned about that, or just doctors and lawyers? Yes, Lori, do something. Meanwhile, this board's protection rate sits at 4%. Why aren't you doing something about that, Lori? Thank you.
Thank you for your public comment.
Is that the last one?
Dr. Hawkins, no additional questions.
So there's a motion that's been seconded. Restatement of that motion.
As I understand it, it is to table the discussion for this board meeting and set it for the May board meeting, bringing back additional information about physician health programs from other states, a discussion of best practices, and then revisit on whether to move forward with this regulatory proposal at that time.
Not to influence folks, but if this motion fails, can another motion be given?
Yes.
Call the question.
Dr. Bulat,
Yes.
Dr. Dingra, Dr. Helzer,
Yes.
Ms. Lawson,
No.
Ms. Lubiano,
No.
Dr. Mahmood,
Yes.
Dr. Thorpe,
Yes.
Dr. Sai,
Yes.
Dr. Yip, Dr. Hawkins.
No.
Motion carries.
The motion carries. Okay. Where am I? Okay. I think we're going to- Moving to agenda item 15, election of a secretary. With the resignation of Mr. Brooks, the secretary position is vacant. And I'm aware that there are 2 nominations for this position.
How are we aware that there's nominations? I don't think we've nominated anybody.
Is there a nomination for secretary? Anyone? Any more, Brimmer?
Yeah.
I'd like to.
Oh, go ahead.
I'd like to nominate Dr. James Helzer.
Second that.
Second? Is there a second? Okay.
I'm going to nominate, he's not here, TJ Watkin.
Is there a second?
I'll second.
You can call for public comment, and then people can vote by saying the name of their person.
Public comment for those in the room regarding the two nominees for secretary, Dr. Heiser and Mr. Watkins.
Patrick Foley, President and members of the board. I'm a little concerned today because when I look at the members of the board, I think all of you are doctors except for you, Ms. Lawson. Who? So you're you were appointed public, okay, I'm sorry, I looked around. But I would think that it's predominantly all doctors. So I would hope that you'd give it another chance so that when you have more board members present, you've got one member absent, is that correct? And he's actually being nominated, and he's not even here. So unless it's absolutely essential, I'd put that off till next month to get as many people on your board as possible to make that determination. Thank you.
Other comments?
Chaplain Reverend Queenie Ruth Summers Tweedle, and I am speaking in reference to Mr. Hawkins. He is the reason why some of us are here, because he has stood up and said that there are some problems with this situation or that situation or other, and he actually got even national news because of him speaking out about situations. And so if you're going to bring somebody into a position to do something authoritatively, well, then it would be a good idea to bring somebody in that does authoritative actions, because that way you will have somebody that, I don't know the other person, nothing against the other person, but you will have somebody that has the strength, the chutzpah to stand up. It's kind of like when we were growing up, when we had to shoot at the mafia, when they were throwing Molotov cocktails at our house when I was 7 years old. My daddy told us to stand up. And so I had to learn to shoot a shotgun at 7 years old when they were throwing Molotov cocktails at our house. And Mr. Hawkins is somebody that is a stand-up type of person, and I think that he would be somebody who would be good to be in an authoritative position, and I doubt whether anybody could help him, would get him to skew things. And I'm saying, I don't know the other person, but I have seen the way that he acts, and so I'm advocating for him to be able to do this. I don't know why he's not here today, but we have people on this board that have not been here for numerous times. But every time I've come, he's been here, except today. So I think he's a good authority figure.
Are you speaking of Mr. Watkins?
I get you guys, you know I call you Hawkins and Watkins and all of that, and Karen Price. But in the meantime, I'm speaking of Mr. Watkins, because that's how I found, one of the reasons why I found out about the board is because he was standing up for the people. Just a thought. Thank you all, and thank you for correcting me, sir.
Other members of the public in the room? WebEx?
Anyone wishing to make a public comment, can go ahead and raise your hand or use the Q&A box to indicate so. If you're on a call-in only line, you can press *3 to toggle raising your hand. First up here, we have Marion Hollingsworth. Marion, you should be receiving that prompt.
Hello, can you hear me?
Yes, we can, Marion. Please go ahead.
Hello, this is Marion Hollingsworth, patient safety advocate. I would like to back Mr. T.J. Watkins for the secretary position. I agree that there's already a very heavy doctor presence on the board, and this would help balance that better. So I urge you to vote for Mr. Watkins. Thank you.
Thank you for your public comment. It's time, Dr. Hawkins. I don't see any additional requests.
Members, when you vote, please say Dr. Helzer or Mr. Watkins, and that's how it'll be counted.
Please call her.
Dr. Balat.
Dr. Helzer.
Dr. Dingra. Dr. Helzer.
I'll vote for myself.
Miss Lawson.
Dr. Helzer.
Miss Lubiano.
Mr. Watkins.
Dr. Mahmood.
Mr. Watkins.
Dr. Thorpe.
Dr. Helzer.
Dr. Sy.
Dr. Helzer.
Dr. Yip. Dr. Hawkins.
Mr. Watkins.
Five to four for Dr. Helzer.
Thank you. I look forward to serving in the role.
Thank you very much. Next item, moving to agenda item 16, future agenda items. You're aware we're pushing hard for artificial intelligence. Any members' future agenda item? Yes, Ms. Lubiano.
Thank you. In several of our meetings, we've talked about the shortage of doctors in our state. And so I'd like an agenda item for us to talk about what can be done in that regard. You know, what are other states, you know, what universities, countries, what are they doing? And, you know, what programs are out there? For example, we heard about the Doctors Academy in Fresno. But, you know, it just made me also think that there's, related to that are kind of the racial and, you know, other socioeconomic factors that affect that disparity and shortage, and also how girls, you know, since the STEM degree is usually an undergraduate degree, you know, we see how girls kind of, you know, maybe they're not as interested in math and things like that. So I'd love to talk about what we can do, what's out there. Thank you.
Thank you. Others? Dr. Mahmood?
Yeah, I completely echo your idea of that. We are really in extreme shortage of doctors. I'll just go 1 point forward and look at the options. The countries, obviously, it's hard to get other doctors from other states, but countries who are sending a lot of doctors, like picking up like top 3 countries and seeing how is the potential to get doctors, not just like pilot program from Mexico, like not doing that. They should do all the requirements, but we should offer them something in California that people can sign up them in California. Like I think 3-4 countries could be India, Pakistan, Mexico, and another 4 country. And we should do this really needs to be done, and we should open up these options. So I will coordinate with your thing, so make it a little bit bigger. Thanks.
Other members? Dr. Balat?
Yeah, this one's fairly specific, and maybe you can help me out a little bit on this one. So today we heard Dr. Alice Kuo. She's a physician scientist, and research is very critical to the welfare of all of our communities and individuals. And one of the things that some of you may or may not know, there is a body that was put together about some 50 years ago, and this will talk about controlled substances, Schedule 1 and Schedule 2s. And the question I have is this Research Advisory Panel of California, which is through the Attorney General's office, or Department of Justice, as my understanding. And my interest is to find out, you know, when we have, there's an LA Times article regarding the challenges of the oversight of these controlled substances, Schedule 1 and Schedule 2, and this RAP-C. So it's the Research Advisory Panel. And I'd be interested to know, because this is at least from the physician scientist point of view, there seems to be some challenges with that particular body. Although we don't have that jurisdiction, it does impact our communities because it's aimed at addiction research. And so addiction research is tied to homelessness and other things. So I think in that manner, I think learning more about this advisory panel and as good stewards of our dollars, just looking about, are there ways that this still has to be in place? That won't be under the jurisdiction of the medical board, but just so we understand it, because it's coming back to us through our patients, and even in primary care, that are looking for alternatives for treatment and they can't get it.
So are you asking about state-of-the-art regarding addiction research?
Yeah, well, I'm talking about the state-of-the-art, but you can't get to the state-of-the-art because there are some barriers to getting to that. And I'd like to learn more. I think it's important for them to learn more about that RAP-C program that the AG has.
Dr. Yip?
I just want to, the physician wellbeing program is already on the future agenda, right?
Yes.
Yeah.
Well, to add on to that, I'd like to see specifically, I know that Ms. Lawson was referring to legislative mandate, what the boundaries of our program must be, and of course, compare and contrast to other jurisdictions in the union on what they've done, and so that we have a more educated and informed decision to make.
I would like to see there's a California represents almost 130,000 plus licenses and maybe 10 to 12% of working force in the country. And we recruit a lot of physicians, and one of the biggest challenges I am observing, or at least got a feedback, can we make the existing physicians who can come to California, the process a little bit simplified, or a little bit more smoother? I think that will be adding to your physician shortage issue. We should also look for physicians who are willing to come to this state, but sometimes they get deterred by the process of it. So just a thought.
Other members before we go to the public? Suggestions, recommendations, requests from those in the room?
Chaplain Reverend Queenie Ruth Summers Tweed. We would like to see help for protected classes, particularly children, and especially from the regard of keeping them under medical supervision to some extent when they are brought in here from other countries saying that they've been adopted, particularly the babies, because the pedophilia that is taking place with our children that are coming in from China, and people are paying $15 to bring the kids in, and it's insane. The Army is working with that already. Along with that, we would also like help for some of the adults, because in some of the senior living spaces, it's a lot going wrong with what's taking place with the adults and people in assisted living, even to the point of marrying sometimes the people that don't get a lot of visitors, and then people taking out insurance policies on them to let them go. Then we would like to have replies that are understandable from complaints that say if something is wrong, what was wrong? Not that something was wrong, that it doesn't meet the bar. Well, what was wrong? Okay. Then along with the veterans that we're dealing with, we really want to deal with over-medicating, them being over-medicated, misprescribed. Some of the veterans that are reporting to our organization all kinds of strange things, including you get a plate put in your stomach and your kidneys and 2 other vital organs taken out because you're supposed to be going in to get a detox. That's insane, okay? And then we want more nutrition education from medical doctors, because you can find out more on the internet about what you should be eating or doing for your body if you have a medical condition than you can find out from a doctor. Doctors don't even know about things like peanut oil and how it helps to stop things from hurting on your body, when you rub it on like a lotion. So it's kind of a thing where our doctors need to have a little bit more, shall we say, holistic, and of course you want physiologists teaching them too, but they also need some holistic training. Did that make any sense?
Yes, thank you very much.
Thank you. God bless everyone.
Anyone else in the room? Thank you.
Michelle Montserrat Ramos with Consumer Watchdog. I'd like to see brought to a future agenda 805 reporting notification on the physician profile. You're already doing it, whether you know it or not. Hospital discipline is listed on the secondary status on the physician profile. What isn't listed is the reason why, such as loss of hospital privileges. So that I'd like to discuss. And also, second to that, started a discussion with California Department of Public Health, who a lot of times is getting this information through their inspections, but it's not being shared with this board in a timely manner. And we come forward when these problems happen, and we lay the blame on your table. But I think it's the betterment of this board and all entities and the public to begin this conversation with Department of Public Health, so they'll bring this information to you in a timely manner. Thank you.
Thank you. Other persons in the room?
Patrick Foley, as I've said before, I really think you have a moral obligation and a duty to live up to your commitment established by the legislature that protection of the public is your highest priority. And in order to do that, you really need to send a letter to the legislature asking for you to be empowered so that when a doctor is charged with felony sexual assault of any member of the public, his license is temporarily suspended until such time as a criminal case has been adjudicated. That serves two purposes. It gets you out from underneath the Attorney General's office having to go before the court on your behalf and citing the justification for the suspension of his license to practice medicine is based on the filings of the district attorney. It makes no sense. And he is in violation of the Medical Practices Act as soon as he's charged with felony sexual assault of an individual of the public or any individual. And you know from this current situation, you are powerless to discipline that doctor now and suspend his license. And that doctor has been able for 2 years to practice medicine without having to notify anybody, his patients, his employer, that he has 2 or 3 felony sexual assault charges against him. And that is abhorrent. You're putting your medical people in the medical field at extreme risk. And that right now is on you. You have a chance to bring this to the attention of the legislature. And that's up to you. Because once you put that in their jurisdiction or their preview, then it's up to the legislature to do something. But if you don't inform them, then it's on you.
Thank you again. Any other persons in the room? WebEx?
The hand raising feature and Q&A window are open for anyone wishing to make a public comment. If you're on a call in the line, you can press *3 in order to toggle raising your hand. Everyone, a few seconds here to queue up. Eric Andrews, if you could do me a favor, if you're wishing to make a public comment, if you could raise your hand or type something again in the QA box. I wasn't sure if your last comment was a request or not. Give everyone a few more seconds here. I'm sorry, we can't take any comments on agenda item 14. We've passed that one already. If you'd like to make a comment on future agenda items, this is the time for that. I'm assuming there's no request at this time, Dr. Hogan.
Well, I want to thank everybody else for their participation, support, comments. Our next quarterly board meeting is May 22nd to 23rd to 24th, correction, May 23, 24, 2024 in Sacramento. It will be an in-person meeting. And thanks again and safe travels wherever you're going to, whether it's down the street or on the other side north. The meeting's adjourned.